That was all about the history of our Subharti. Now moving on with the program. Working diligently and settling for nothing less than perfection is the man who is the driving force behind this conference, Dr. Brigadier S. Sudarshanam. He is the organizing chairman of the IPS Central Zone Midterm CME. He is professor and head Psychiatry. He is a soft-spoken man with great vision and determination and a constant source of inspiration for many. He has earlier served as professor and head Psychiatry at AFMC and held important academic and clinical appointments in Army Medical Corps. Proceeding with the program, I request Dr. Sudarshanam to kindly come forward and give the welcome address.
There were due to very unavoidable reasons, and I hope you bear with us. It is my proud privilege to welcome you all on this inaugural function of the IPS Central Zone Midterm CME on behalf of the organizing committee and the Department of Psychiatry. At the outset, may I express our warm greetings and welcome to Dr. R.K. Srivastava, Director General Health Services, Government of India, for gracefully accepting our invitation to inaugurate the CME. He has a very busy schedule, and thank you very much, sir, for spending your valuable time with us. I also extend our warm greetings to Dr. S.K. Tandon, President, Dr. S.P. Gupta, Secretary, and all other office bearers of IPS Central Zone. We are indeed grateful and honored by you for giving us this opportunity to host this conference. We extend our heartfelt welcome to all our speakers. Dr. Usha Naik, she is, as mentioned, formerly head of Child Psychiatry in Osmania University. She happens to be my classmate's sister, and that gives a special regards to you, ma'am. Dr. Subharti, Dr. Jiloha, Professor and Head of Psychiatry, Maulana Azad Medical College, New Delhi. Dr. Prabhat Sitoli, formerly Professor and Head of Psychiatry, KG Medical University, Lucknow. Dr. K.E.S. Unni, Professor and Head, Department of Psychiatry, Lady Hardinge Medical College, New Delhi. And Dr. Amit Rastogi, our endocrinologist and Assistant Professor in the Department of Medicine. We welcome you all, sir. They are stalwarts and highly experienced teachers who agreed to our request at very short notices. We are indeed honored. We extend our warmest greetings to Dr. P. Bhatnagar, our founder president, for facing this CME. Her amazing dynamism, vision and perseverance has been highly inspiring to all of us. Our warm welcome to Lieutenant General B.S. Rathore, our Vice Chancellor, who gracefully consented to be with us to honor us this way. We extend our greetings and welcome to our dear Principal and Dean, Dr. A.K. Asthana, who has given us tremendous encouragement, guidance and support. Last but not least, we extend our warmest welcome to all our faculty members, dignitaries, delegates, postgraduate students who have honored us by their presence. We have also extend our warm welcome to the press and media. I will also like to convey my sincere appreciation and gratitude to Dr. Chowdhury and all his team members, all my faculty, my PG students. I'm sure we have shortcomings, this being our first conference. However, I like to give all the bouquets to them, and if there is any shortcoming, the district is mine and I take the blame. Please free to convey your opinion, suggestion. We have a feedback form. You're most welcome. Thank you.
Is our organizing secretary, Dr. Sandeep Chaudhary. He's the Associate Professor of Psychiatry in Subharti Medical College. He's trained in child psychiatry from US and UK. I invite Dr. Chaudhary to address the group.
Thank you. Respected Dr. R.K. Srivastava and other senior dignitaries for participating today from Subharti group of institutions and other senior teachers and our esteemed speakers, my teachers, Dr. R.C. Jiloha, Dr. Prabhat Sitole, Dr. Usha Naik, Dr. K.E.S. Unni, and Dr. Amit Rastogi, and my dear postgraduate students of Psychiatry and other branches of medicine who have come to participate here, and many other psychiatrists who have come here. Actually, when I was given this opportunity to hold this event here, it was just one of our senior psychiatrists. He's also participating in this, Dr. M.R. Jawar from Varanasi. He asked me to take this up because I was always in Varanasi at the earlier times. So I took it up, and here you are with us. Our department is just a decade old, and we are 40-bedded inpatient unit. We have an OPD which runs around with 80 to 100 patients per day, and we have 80 to 90% of patients inpatient. And then we are with our leader, Dr. Sudarshan, as HOD and professor. Then we have 2 associate professors, 1 AP, 1 senior resident, and 3 junior residents in the department, with other 2 psychologists, clinical psychologists, and other paramedical staff. This is a small department, and we've tried our best to do whatever we could for this event. And when I got this opportunity, the only thing which was there in my mind was child psychiatry. Because child psychiatry, I love child psychiatry, it's my passion, and I personally feel that child psychiatry is still in an infancy in this country, and it has to grow. It will grow, and I'm sure many of you will take up this in future, because you are our future. And with this, we ended up with some discussions in the department with our Dr. Sudarshan, who's a biological man with biological psychiatry. We got de-addiction included, we got psychoendocrinology included with our other themes. So finally we were there with 3 main themes, and we have tried to do our best to get the best teachers in front of you to provide their knowledge. In spite of our shortcomings, which could be there during the day, we have tried our best, and I'm sure you will go back with a lot of intellectual feast. Thank you.
Thank you, sir. Now I feel honored and privileged. Dr. R.K. Srivastava was a specialist in physical medicine and rehabilitation, and he has produced many manuals for WHO, like Manual for Trainer of Spinal Cord Injury, Training Manual and Operational Manual for Community Level Functionaries in Medical Rehabilitation. He has contributed chapters in the textbook of geriatric care in India and handbook for pediatric surgeons on disability-related subjects. He has been organizing sports for handicaps at state and national level. He is a member of selection committees for many national awards and a member of various executive committee, board of directors in national institutes in India. He is a recipient of many awards, and to name a few related with orthopedics are the B.N. Sinha Award, T.P. Jhunjhunwala Award, Shrestri IPMR KGMU Award, and now Professor A.M. Srivastava Annual Oration Award in 2008. Let us give a very warm welcome to Dr. Srivastava and invite you, sir, to thank you for the inaugural address.
Good morning. To the announcers who have given such a exhaustive introduction about myself and my study. All those things which have been mentioned are available with each and every person who is sitting over there. The only difference is that some things are spoken and some things are not spoken. Ladies and gentlemen, this is my first visit to this educational institution. I had been visiting good number of medical colleges, medical universities, both in public and private sector. But somehow, in spite of belonging to this particular city, I have never visited this institution. It is really very impressive. From the time you enter into it, you have got a feeling that you are entering into an institution where there is a real sense of commitment for quality teaching and training. So my congratulations to the founder president, Dr. Mukti Bhatnagar, for nurturing such a nice institution. I hope that it will grow further in all the sector of the education, not only confining to the medical or dental, but the vast area in which education is growing world over, and also be gradually integrated within this education setup. Has become a very, very important area for a country like India, where trained human resources are not that many as is required for delivery of the services. So such type of institution, if they develop, they expand, they produce more human resources which is utilized for the service development in country. We have got about admission capacity of about 2,000, and there is a wide variation, starting from medical, dental, pharmacy, fine arts, engineering. So we have got all the potential. Now coming back to the theme of this particular continuing medical education. I said child psychiatry is one of the very important areas where most of the psychiatrists working anywhere in the country, they require continuous training. In the central government hospitals also, the best of the department of psychiatry are available in Maulana, All India Institute, Aravan Hospital. They have got a very, very small nucleus which are developing in this particular sector. So a team like this for a continuing medical education will definitely be very, very useful. And if you look at this particular team in light of the various type of changes which are happening in India or world over in the sector of the mental health, you will realize that the large amount of changes which are being brought about in the mental health sector, they are focusing towards providing protection and care to the right of children who are being affected by mental health. If you look at the national program for mental health, this time in the planning of the 12th plan, there is a focused approach which has been given to the mental health of children. If you look at the media reports which are coming, there are volumes of reports which describe about the impact on the high tension educational system in the performance of the children. So there is a lot of things which are happening in the mental health sector which are improving or increasing the focus on the child mental health. So such type of endeavor by the Indian Society for the Psychiatrists, Zonal Branch, Central Zonal Branch, is going to have fruitful effect in building the capacity of the young psychiatrists so that they can work together with the various programs and projects which will be launched in the coming time. So my good wishes to the organization which has initiated, to the zonal group which has taken it forward, and I am looking forward for having some type of strong recommendation from such type of meeting also, which can be incorporated in the child psychiatry component for the country. You are all professionals and you know much more about the mental health and the field in which you are going through. So, kindly take care of certain things which I am sharing with you about the mental health. As you know, mental health is a very complicated type of area which has not been able to make much changes in spite of large amount of the financial input which has been provided by the government. The last time central funding was about 1,000 crore rupees and the focus was to develop center of excellence and build up the capacity of medical college so that we can produce major 4 categories of human resources which are involved in the mental health. Psychiatrists, psychiatric nursing, medical psychologists and medical social workers. Out of the total investment, we identified about 11 centers of excellence. We invested money. We have been able to start already 10 to 12 new courses. The investment government is making and the outcome. This is one area where the professionals need to work together and generate more and more manpower. The team in the trust plan will remain the same. I have been told that the total number of psychiatrists who are available in the country as per their registry is hardly 7,000. Am I right?
It is 4,000.
4,000. Now this is, I don't know whether it is a live register or it is not a live register. But if you look at the country's requirement, then there is a huge gap between the demand and the supply. If you look at the availability of the para professionals who are involved in the mental health, the gap is same. I have been discussing it with large number of the psychiatrists and Dr. Biloy sitting over here. Dr. Sridhar Sharma was previously involved in all these things. We have talked to them also. In that, unless and until you are able to put the focus on human resource generation, you will never be able to take care of the psychiatric ailment in the country. So when the government is funding, the money is reaching to the institution, usually they are attended by the young psychiatrists who are working in different parts of the country, some postgraduate, and the expectation of this group is quite unknown to the organizers of the scheme. In majority of the disciplines, when we organize a CME, we organize it according to what we feel is important. We do not look at the expectation of this particular group, what they need. We have worked it out when we used to organize the CME in orthopedics. We have had a system of taking a feedback from the 4 hospital participants of the CME program and decide the theme of our continuing medical education accordingly. There used to be a system of receiving input from the young participants before the CME is decided, its theme is identified and the speaker faculty is invited. That used to be debated in the group, this is the group of the organizing committee, and that way we have been able to attract just double the number of the participants in all the continuing medical education program. I am not preaching it to be followed. I am just sharing with you. If you find a sense out of it, please think about it. Because no CME is going to be useful unless and until it matches to the requirement of the participant and they keep on waiting for the day of the CME. They keep their ears open where faculty is talking about the various types of components on various type of project, and they get benefit maximum from their continuing. Times is changing fast. Without CME, you cannot keep yourself updated. And if the CME is a gap-filling arrangement in the young psychiatrist or young professional and the seasoned faculty, that is probably the best. The key word I would like to conclude, and I will convey my best wishes to this continuing medical education program in psychiatry from right minded to the sector. And I will again like to congratulate this institute which has established a fantastic structure and which is trying to support the educational activities so much required in this sector. Thank you.
Thank you, sir. Your kind words will be a source of inspiration for all of us to perform better. May I request our Honorable Vice Chancellor, Dr. Lieutenant General P.S. Rathore, to kindly release the souvenir.
मैम प्लीज यस यस सामने देखिए मैम यस
May I now request you, ma'am, to present a memento to Dr. S.P. Gupta, our guest of honor, General Secretary, Indian Psychiatric Society of the Central Zone, and a token of appreciation. Teacher, orator, a spiritualist to a patron of art and culture. She has donned her many hats to perfection. She is the founder of Subharti Institution, Professor Mukti Bhatnagar. I would like to mention it here that ma'am has insisted specifically for giving the vote of thanks, and I invite you, ma'am, to kindly deliver the vote of thanks.
I have had a lot to do working with Brigadier Sudarshanan. Brigadier Sudarshanan was introduced by Dr. Chaudhary just now as a biological man. I thought Dr. Chaudhary, all the men here were biological men, or am I mistaken? Okay. I mean, it's like being Lord Krishna, you know, कहते हैं कि दुनिया में एक ही मर्द है, वो है कृष्ण, और सब तो महिलाएं हैं. So, biological man, I suppose, I don't know about you people. Anyway, मैंने एक मरीज के लिए सुदर्शन साहब को अभी कंसल्ट किया. एक सुंदर सी लड़की थी, and she was a hypochondriac. As we all know, she was obsessed with a lot of diseases in her body. तो मैंने कहा सर इसका जरा ट्रीटमेंट में मदद कर दीजिए. तो he looked at me very intently. He said, send her to me. I said, साहब क्या करेंगे? So he said, I'll tell her कि stop thinking about your own body and start thinking about somebody else's. So I looked at him. I said, sir, medicine का मरीज है, तो let my head of the department, General Virmani, have the pleasure of giving this advice to that sweetie girl. So that is regular. Minister. Then of course the next is Dr. Chaudhary. चौधरी साहब आए जब हमको बुलाने तो हमने कहा तुम्हें फंड्स की तो कोई प्रॉब्लम नहीं है. He said नहीं मैम, एक्चुअली हमारे मरीज स्प्लिट पर्सनैलिटीज होते हैं, so we have a lot of funds from insurance companies. So I said, insurance companies or the pharma companies? He said नहीं मैम, insurance companies, because they take a double policy on all our schizophrenics, so they are happy to sponsor us. I said thank you, how nice. I wish our medicine people could learn more from that. And the final was Dr. Sachin. In his brigade mein, he is an assistant professor here. He is my friend and I often go to him with my own problems. और हम बहुत परेशानी में रहे हैं, क्योंकि जब भी कोई चीज बनाओ तो परेशानियों की कोई कमी नहीं रहती है. तो मैंने कहा लेकिन सचिन अब हम ठीक हैं, because I pray a lot, I've been introduced as somebody very spiritual, so I pray to God. I say लेकिन अब भगवान जो है वो हमको बात करते हैं, हमको मार्गदर्शन देते हैं. He talks to me. So Sachin looked at me, he said, ma'am, when you talk to God, you are praying, and when God talks to you, you are a schizophrenic. So here is the final president of Subharti. और प्रॉब्लम कहाँ आ गई? मेरे हस्बैंड को ये बात पता चल गई. माय हस्बैंड डॉक्टर अतुल कृष्णन, तो उन्होंने कहा ये शिजोफ्रेनिक है, कहीं ऐसा ना हो, एंड ही मूव मी फ्रॉम द पोस्ट ऑफ प्रेसिडेंट टू फाउंडर प्रेसिडेंट ऑफ फ्लावर पोस्ट. तो मैंने कहा अतुल तुमने ऐसा क्यों करा? कि सर देखो आई एम बीइंग वेरी फ्रैंक, कहीं तुम चेक साइन कर दो और कह दो मैंने नहीं उसने साइन किया था. तो ओके, सो आई एम इन फ्रंट ऑफ यू, ऑल्दो दैट इज ओनली प्रोफेशनल. Now my husband, when he comes home, he legally asks the guard कि कौन वाली घर में है, ये वाली की वो वाली. So, चलो, that is right. Amongst the audience, the only person I met the second time is Dr. Umi Krishna, who helped us start our post-graduation. इस उम्मीद से कि बढ़िया post-graduates बनेंगे हमारे यहाँ. So sir, you are right. We have very practical post-graduates and very well trained by Brigadier Sudarshan. मैं सिडेनाफिल पे, सिडेनाफिल वायग्रा, तो इनका पीजी आया हमें जब बुलाने के लिए, तो मैंने कहा बेटा सबसे बढ़िया एफ्रोडेसिया क्या है जो तुम जानते हो? तो he looked at me and he said, मैडम मनी. So that is the training you've given. So well, it's very practical. So I think you will be happy with the progress your PGs have made over here. Anyway, so I thank you again, and I especially thank Dr. Srivastava, who has braved the traffic to come over here. Of course, he was very restless, but then all orthopedic people are, if they don't get broken bones, they break bones. वो बिना काम के बैठ नहीं पाते हैं. लेकिन पहला सवाल जब उन्होंने देखा, उन्होंने कहा मैडम ये मैनिक्वेंस पे आप लोग ऑपरेट करवाते हैं, डोंट यू हैव कैडेवर्स? ऐसे नहीं सर, एनाटॉमी डिपार्टमेंट कैडेवर्स. तो ही सेड हाउ डू यू क्रिएट कैडेवर्स? सो आई सेड माय प्रिंसिपल क्रिएट्स देम. डॉक्टर साना क्रिएट्स कैडेवर्स. ही इज आफ्टर ऑल एन एनाटॉमिस्ट एंड ही वुड लव टू क्रिएट मोर. तो उनकी तरफ से है कि इफ एनीबॉडी वुड लाइक टू वॉलंटियर, anybody, then please give your name. We'll very well welcome, but we are actually having cadavers, we don't have mannequins. So a big thank you for all of you coming again, and please मैं डॉक्टर अतुल की तरफ से भी कह रही हूँ, and I'm actually myself when I'm talking this, I am not the other person, कि मैं आपका हार्दिक स्वागत करती हूँ और धन्यवाद करती हूँ कि आप सुभारती में आए और हमारे सुभारती की शोभा बढ़ाए. धन्यवाद.
Thank you so much, ma'am. With this, we have come to the end of this inaugural function, and I now request you all to stand up for the national anthem, after which we will take a short break of 10 minutes, and the scientific session will resume as per the schedule in the council hall. Thank you all.
यमुना गंगा उज्जल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाए तब जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Another comment was that the two streams, psychiatry and endocrinology, they are coming together and it must make an interesting subject to progress. We all know that certain diseases like hypothyroidism, Cushing's, calcium, they all make a lot of impact on the presentation. Now, to give all the details, we have got our speaker, Dr. Rastogi, and he will be speaking on this topic and elaborate on this concept. Dr.
And I welcome you all on the field. Going through the literature, I found this reference way back to 1959 when the book edited by Max Rees was published. And at that time, this field was evolving and a lot of change have been made during the past couple of years. So I wondered when this topic was given to me, what should I speak for this topic and to make it more interesting to the audience. And when I took the sub-specialty of endocrinology, that is different systems of endocrinology, and I was surprised that not even a single system was left untouched by psychiatric manifestation. These are the common organs which we often deal with endocrine system. Talk of pituitary, the master gland, situated in the brain. It has an anterior and a posterior part. The anterior part synthesizes a lot of hormones, trophic hormones which we say, and the posterior part, that is the antidiuretic hormone. The anterior pituitary pathologies may present to you with psychiatric manifestations. To talk of few, like the acromegaly, prolactinoma, non-functioning pituitary adenomas can present to us for the first time with the mild psychiatric symptoms. What to talk about the posterior pituitary, that is the antidiuretic hormone defects. We all know of syndrome of inappropriate ADH secretion, which present to us with hyponatremia, and is such a common biochemical abnormality which we see in the clinical practice, can present to with constellations of psychiatric manifestations. Thyroid disorders, hypo and hyper, we all know of. It's very easy for us to comment that it's a case of hypothyroidism or it's a case of hyperthyroidism. But still these entities are being misdiagnosed or not being diagnosed at an appropriate time. So much so the delay in the diagnosis is made that this poor patient finds himself in various specialties except for medicine or endocrine department. Adrenal glands situated above the kidneys, they also have the hypofunctioning and hyperfunctioning. Parathyroid gland, which involves the calcium metabolism. We were talking with Professor Sindoli this time and he narrated to me one of the cases which was being dealt as a psychiatric manifestation and diagnosis was that of hypoparathyroidism. Hyperthyroidism is a new entity which has entered the medical field and it has various neuropsychiatric manifestations. Gonadal function we know are very important in maintaining a good cognitive functions and a healthful life. We know about the Turner syndrome and Klinefelter syndromes, trisomy and monosomy. They are present with behavioral abnormalities. Now the pancreas. The pancreas is the gland which we all know And the most common endocrine problem which we see is diabetes, which originates from the pancreas. And we will discuss in a short period of time later, that is diabetes and psychology. Another important pathological lesion which we see in pancreas is a benign tumor known as insulinoma. I can go on. Insulinoma produces lots of insulin. Patient keeps on coming to one emergency department to the other with hypoglycemia, but the diagnosis is not made. And the latest entry into this field is the disorder of sex development and the gender identity disorder or transsexualism, as we say in our branch. To complete the list is porphyria or some vitamin deficiency like vitamin B12, thiamine and also. These are small things, but they make a lot of impact in the clinical presentation. Before stepping forward, just a basic of endocrinology. That we have a 3-tier system: hypothalamus, the pituitary, and the target glands, be it adrenal gland, be it thyroid gland. The defect lies in the target gland. The message is given to the pituitary and hypothalamus to produce more of the hormones, and this is the primary hypothyroid or adrenal insufficiency. When the defect lies in the pituitary, their trophic hormones will also go down. Just the primary disorder, that is primary hypothyroidism or secondary hypothyroidism, just to differentiate it, please. Now I would draw the attention of the audience. I bring therefore some 3 interesting cases which we dealt in the Subharti Medical College in the combination of Psychiatry and the medicine department. Let's go ahead. So this is a case of 21 years old male patient who presented to us with recurrent vomiting and fever for the past 6 days. He was in a state of shock. The fundus examination was normal. There was no meningitis or meningismal sign present. He was hospitalized, managed symptomatically, and was discharged. This patient was dealt with a gastroenterologist. He did the upper GI endoscopy, that was normal. Other electrolytes was not done, but the other biochemical parameters were normal. To the surprise of the patient and to the inmates, the same individual found himself in the emergency department in the evening. But this time something additional happened. Apart from vomiting and shock, he also had altered behavior and visual hallucination. Oh my God, these are psychotic symptoms. This time a CT scan was ordered by a neurologist. This time the neurologist came into play. CT scan was normal, but something important or something logical clicked to the neurologist. It did with presentation of vomiting, psychosis and altered behavior, low sodium levels, and with a beautiful sign of hyperpigmentation. And when you combine all these 3 triads, I need something to... Now the things are pretty simple. Hyperpigmentation, hyponatremia, patient presenting every time with shock. The diagnosis is primary adrenal insufficiency. A very common endocrine disorder which we have been studying since our undergraduates, postgraduates, but this probably diagnosis was a bit delayed. How do we approach to a case of primary adrenal insufficiency? We got the serum cortisol level done, they were grossly low, and we got the ACTH done. ACTH was high, meaning thereby it was primary adrenal insufficiency. The gold standard to confirm this disorder is to go for a Snellen test, but with the background of clinical picture and the biochemical parameters, we usually avoid it. These are the photographs of the patient in comparison with his brother. You can see the pigmentation in his palms. Next. This is a comparison with that of his brother. You can see the marked difference between the pigmentation. Next. The primary adrenal insufficiency was first time described by Thomas Edison, and this led to the insight into the endocrine disorders. He described as anemia, general debility, remarkable weakness of the heart section in terms of shock, irritability of the stomach like diarrhea, vomiting, and peculiar changes in the color of skin. Next slide. These are the various symptoms. They may be variable, but most often they are fatigue, depression, abdominal pain. This is the feedback loop I was talking of. You have three-tier system. You have hypothalamus, pituitary, and the adrenal glands. Once the adrenal glands go out of order, the pituitary and hypothalamus, they increase their secretion, and that's why we catch hold of the diagnosis of primary adrenal insufficiency. Next. These are the symptoms, and these are the common biochemical abnormalities which we see. Never leave a patient of hyponatremia as such. Always try to make the diagnosis what is causing to hyponatremia. Next. Now I bring you to the second case. This is a very interesting case which we dealt during my initial stage of working in Subharti in association with the Psychiatry department. This is a 36-year-old female presenting to us with a non-specific complaint. In fact, the most common complaint which we see in this particular gender and in this age group, ghabrahat, palpitation and anxiety. She had a history of weight gain for the past 4 months and have fatigue for 3 months. There have been a history of hysterectomy 2 years back. Next. Now have a look over the symptoms and signs, examination. She is grossly overweight. She has centripetal obesity, hypertrichosis, pink molluscous striations. She was hypertensive. She had proximal muscle weakness, muscle atrophy. And I am sure that 100% diagnosis will be made on this particular examination. This is nothing but Cushing's syndrome. I need not to go further with this beautiful presentation of the clinical signs the patient was having. And goiter, tremors and proptosis was absent, because with ghabrahat, palpitation, anxiety, the first thing which comes to our mind, it might be hyperthyroidism. These are the quite variable symptoms of signs of Cushing's syndrome. But to be very specific, the specific signs of Cushing's syndrome are centripetal obesity, easy bruisability, ecchymosis, proximal muscle weakness, and pink striations which are present in the abdomen. And all these were having in this patient. But this patient was, because of her cognitive dysfunction and maladaptive behavior in the psychiatry department. Next slide. The diagnosis was no doubt Cushing's syndrome. Once we have Cushing's syndrome, we tried to differentiate whether it is an endogenous or an exogenous. Exogenous means that patient has taken a lot of steroid from outside. That means iatrogenic. Because that's the most common cause of Cushing's syndrome which we see in a clinical practice. Patient might be getting steroid for no rhyme or reason, like skin, maybe the skin lesions, arthritis, COPD, respiratory tract. You talk about a medical condition, steroid is given. Now another differential diagnosis which I would like to entertain in this condition was pheochromocytoma. It is a benign lesion originating from adrenal but from the medulla, and it produces lot of catecholamines which may lead to hypertension in this age and all those symptoms of ghabrahat, palpitation, anxiety. Last would be premature ovarian failure. We all know of the natural menopause which we see, climatic symptoms. They mimic like this only, ghabrahat, palpitation, anxiety. Because this lady had hysterectomy done, it was very difficult whether to ascertain whether she is having or preserved gonadal functions or not. And I am sure that nobody would entertain the diagnosis of hyperthyroidism in this case. Next slide. So when we have a patient of Cushing's syndrome, first thing is to rule out whether it is an exogenous or endogenous. For this we get a basal morning fasting cortisol level done. And in this case, the basal cortisol was 19.5. The range is 4.5 to 22.5. It's on the higher side of normal. Had it been exogenous, it would have been suppressed. Because if you give any hormone from outside, the body tries to subdue its own secretion. And this is how we differentiate between an exogenous and an endogenous Cushing syndrome. Next. And these are the subsequent tests because the region, to be very broad, may be in the pituitary or it may be in the adrenals. Pituitary is known as Cushing disease, in adrenal they are benign adenomas. We did confirm the diagnosis of low-dose DEXA suppression test. I need not to go into detail how to be conducted. But when you give steroid from outside, the cortisol level should have gone down. But in this case, they were still high. And once you confirm the diagnosis of endogenous Cushing, you want to localize it, whether it is a pituitary origin or it is an adrenal origin. So we get an ACTH done. ACTH was well below the normal limit. That means the tumor is in the adrenal glands. Had it been in the pituitary, the ACTH would have been high. Simple. Next slide. So this case was diagnosed to be a case of an adrenal Cushing syndrome. And if you ask me about my experience, which is very short, this may be only the second or third case during the span of say 5 years of adrenal Cushing which I have seen. Please. So we get an FSH done. Had it been premature ovarian failure, we expect the FSH to be high. It was normal. We have another telltale sign of hypercortisolism, that is there were fractures which went unnoticed. We get an CT scan done and we found a beautiful, well-defined marginated mass in the right adrenal. And this patient was operated, and pathologically also this mass was found to be a benign adenoma, and patient was cured of this disease, of a disease. So you can see that adrenal glands, one with primary adrenal insufficiency, another with Cushing syndrome, landed up into a psychiatrist or a neurologist. So these small things have to be kept in mind when things are not improving. Next thing. This is how the corticosteroids affect the central nervous system. They can influence the mood, excitability, and they also have impact over the electrical activity of the neurons. Behavioral changes we have seen both in hypocortisolism and hypercortisolism. In a depressed patient, we often find an heightened HPXs, and at times a morbid depressed patient or a major depressive disorder patient might have some subtle signs of Cushing syndrome. This is because of the heightened HPXs. It may not be any pathological, and this is a condition which we call as a pseudo-Cushing's. And sleep disorders which we commonly see, one we give a patient a steroid, initiate a steroid therapy for some autoimmune disorder or anything. Next. Now, not taking much of your time, I bring in front of you the third interesting case which has a combination of both psychiatry and endocrinology. A 24-year-old female presented to us with abnormal behavior including violence and abusiveness. You can see the prime presentation of this patient. She had catatonic features, that is postural rigidity for 1 year, menstrual disturbances for 3 years, eating problem, and loss of organic reflex. Next slide. And this is what we found in this examination. She had a pale look, dull look, expressionless look, puffiness over the face, sparse scalp hair, dry coarse skin with ulceration, hoarse voice, bradycardia, hypotension. There was rigidity, plantar was not disturbed. Diagnosis is simple. Next slide. But because of the glaring psychiatric manifestation, and there is no doubt that you will first entertain the psychiatric problem in this case because it was so glaring, and this was entertained as catatonic schizophrenia. They were right. It's rightly diagnosed. Next slide. These are the investigation done. You can see she was having anemia, a feature of UTI. X-ray revealed fracture of the lateral end of the right clavicle, and there was stones in the gallbladder, which are asymptomatic. And then the mother of all tests was done. Next slide. And this was the end of story. That patient was florid hypothyroidism. But you can see the presenting symptom of this patient: agitation and violence. And what traditional teaching have been, the patient is subdued to herself or himself, and he is a pathetic state. And this is the very rare presentation of hypothyroidism and known as mixed edema madness. Very few case reports you will find in literature. Next slide. And you can see that how hypothyroidism, when undiagnosed, can lead to these consultations. This patient had a consultation from a dermatologist. She would have found herself in a skin department because of crisis and ulcerations. Pleural effusion, a part of manifestation of hypothyroidism. TB test, anemia and raised SLP, orthopedics, surgeon, and a gynecologist too, to complete the list. This is how hypothyroidism have a varied spectrum. This is again the axis which I was talking about, the feedback mechanism. Symptoms, just to have a look over the hypothyroid symptoms, all those which were present in this patient. Next slide. And this is how thyroid dysfunction or thyroid importance is in our brain development. We all know about the congenital hypothyroidism or iodine deficiency disease. Cretins we all know of. Such an important thyroid hormone have in the brain development, right from in utero. The patient may be present with severe anxiety and agitation, and this is what we have the case of myxedema macus. Next slide. These are the other reversible neurological symptoms of hypothyroidism. Cerebral ataxia, carpal tunnel syndrome. Another important thing is manifestation of hypothyroidism is Hashimoto's encephalopathy. The patient can come to a neuropsychiatric department or in the medicine department in a focal neurological deficit, seizure or altered state. You get the thyroid function, it might be normal, but you get the antibody titers done, they are high, which is the marker of autoimmunity, and the treatment is steroids. Next slide. This is how the hypothyroid patient can find himself or herself in a psychiatric department because of psychosis, which we have seen, affective disorders and cognitive dysfunction. Next slide. But how do you treat this patient? It's a live case, it's a genuine case. So I just want to brief you that how do you manage this case regarding the endocrine problem is concerned. Next. So you start with the levothyroxine replacement, and this will lead to a gradual improvement of the patient. Next. Delusion hallucination will remit in 1 to 2 weeks. Next. Now one point of caution is, don't start with a very high dose or a rapid titration in this patient. You found that she is a case of profound hypothyroidism, TSH more than 60. It can be 100 in 200s. But start with a very low dose. Because if you start with a very high dose or in a rapid titration way, this will aggravate the psychosis. The tissue do not know where the thyroid hormone has gone. You give the high dose, this will excite them. And this will cause acute psychosis. Next slide. An addition of an antipsychotic can lead to an early remission of this case. And the choice is the low dose atypical antipsychotics. You are the best judge which one to add. Next. Next. So this is about the clinical experience and which will further strengthen the bond between the psychiatry and the endocrine fraternity. So some of the recent topics of interest which I found in this endocrinology subset was diabetes and depression. The commonest endocrine problem which we see today is diabetes. Another are eating disorders. I found that a passing reference that the use of 5-alpha reductase inhibitors in schizophrenia. This is a passing reference. Gender identity disorder and disorder of sex development. And last, that is androgen effect on brain. I'll not be talking of all these components, but few points or the few topics needs a discussion. That is diabetes and depression, GID and PST. Next step. Now recently, 2009, Endocrine Society of Clinical Practice, they formulated a guidelines among the transsexual person. And you see the first sentence, the diagnosis of GID, as it is called in psychiatric fraternity, may be made by a mental health professional. So you are the best person to diagnose this particular disorder of GID. For those who are dealing with children and adolescents, we are talking about child psychiatry. The MP, that is mental health professional, should also have a training in child and adolescent development psychopathology. Next slide. So this subject is in transition. So we adjust the psyche of the patient, and then we can suppress his or her puberty. We can give the cross-sex hormones. We ask the patient to go for the sex reassignment by the surgeries. But even then, that's not the end of story. The role of psychiatrist remains lifelong. Because once we follow these patients, this is an 18-year follow-up. And those male who opted for a female gender, they had a high mortality. And this was primarily because of suicide and drug abuse. So this is the importance of a psychiatrist in this particular branch. Next slide. Now this is the other topic, that is DSD, disorder of sex development. Next slide. This is a consensus statement which was passed in 2006. Terms we often use in our clinical practice are no longer to be used. Like intersex, pseudo-homosexualism, they are particularly controversial. They must be replaced by the terminology known as disorders of sex development, which is defined as a congenital condition in which development of chromosomal, gonadal and anatomical sex is aided. Next slide. This is how the revised nomenclature is. Intersex is being replaced by DSD and so on. So it is a multidisciplinary team effort in management of DSD. And the team constitutes an endocrinologist who has been specialized in pediatric endocrinology. As we all talk about child psychiatrists. So is the importance of them in this particular stream. Next slide. The psychosocial management of DSD, what is the role of a psychologist or a psychiatrist? They facilitate the decision making about the gender assignment and reassignment. They are the one who decide what is the timing of surgery and when to replace the sex hormones. And the most common problem encountered in DSD patients are sexual aversions and the lack of arousability, which are often misinterpreted as low libido. And the focus should be on interpersonal relationship rather than on sexual function and activity. Next. Now this is the topic which is very hot in endocrinology, depression and diabetes. As a diabetologist or endocrinologist, we must have a psychiatrist as a part of diabetic management team. This is becoming an order of day nowadays. Next slide. And the insight, it's a double-edged sword. Depression can lead to diabetes, and diabetes have more chances of depression. If I come to the first, that is a depressed patient having an insulin resistance, the data goes back to 1988, published in American Journal of Psychiatry. You can see the glucose and the insulin were high in depressed patient as compared to a control. Next slide. And this was a recent article which I could cite. And clinically significant depression is associated with 65% increase in the risk of diabetes mellitus. Next slide. Coming on, you can see that all the other parameters of depressions are associated with diabetes. Be it non-severe or severe depression, having the first episode of depression or a previous episode, persistent depression or antidepressant treatment. Only one thing had a reduced risk of diabetes, that was treated depressed patient. You know, there are heterogeneous drugs, many drugs of different classes which are being used for as an antidepressant. Some of them may have a good glycemic profile. So that's why there was the relative risk reduction in this group. Next slide. And now we talk on the other part of the story. Are diabetic patients more depressed? Yes, they are. You can see this particular graph, and it was to the tune of 11 to 31%. Next slide. So how depression affects a diabetic? Worsen the self-care and treatment adherence. It is related directly with the poor glycemic control, and this leads to the comorbid condition and mortality. Next slide. And the combination of depression and diabetes is now being referred to as a diapression. Next. So depression can mimic or it can amplify diabetes symptoms. Depressed patients have low mood. Their motor skills are subdued. This may be the presenting symptom of uncontrolled diabetes, but the first time the patient can present to you with diabetes. Diabetic neuropathy is known to all. A depressed patient perceives these symptoms more than a patient who is non-depressed. So this is how a depression can mimic or it can amplify a diabetic symptom. Next slide. Depression is associated with poor self-management and treatment adherence. Patient forgets to take his pill, forgets to take insulin injection, and this leads to poor control of diabetes. Next slide. It can lead to the adverse lifestyle habit. And the two important adverse lifestyle habits are the eating disorder and cigarette smoking. Eating disorder, it can be bulimia, it can be binge eating. And one syndrome which I found in the literature new is night eating syndrome. These depressed patients, they wake up in the night because of insomnia and they try to revert their symptoms by eating more. Their glucose profile goes haywire, and secondly they put on weight. And you are in a fix. What is happening to this patient? Why is putting on weight? In spite of all my remedy, the patient is depressed. Second, next please. Depression is associated with changes in life care and utilization pattern. Now this can affect two ways. A depressed patient can take an appointment and will never follow that appointment. His visits go down. On the other hand, he is so depressed that he'll phone you, he'll poke you in the wee hours of night, Dr. Saab, I'm having this symptoms and that symptoms, and he'll not comply to it. Next. Last, that symptoms of depression reduces the level of trust and satisfaction with care. Doctor shopping is what I am talking about. Next. So these are the drugs of different entities. Mainly I highlighted the antidepressants, some of the antipsychotics and mood stabilizer also come. So just should keep in mind the drugs which we are prescribing to the patient who is a diabetic. For example, fluoxetine and bupropion, they reduce actually in weight. Some of them are weight neutral and some of them cause a dramatic weight gain. So we should take care when prescribing the antipsychotic antidepressant in a patient who have a high risk of being a diabetic or is a diabetic. Next slide. So points to remember is, should monitor the weight vigilantly and intervene promptly at the first sign of excessive weight gain. Should not wait for the weight gain following the drug administration to exceed 7% that has been taken as cutoff. Second, do not prescribe a higher metabolic risk medication without a compelling reason. And as the old saying goes, prevention is better than cure. Always promote a healthy lifestyle of the patient when you are prescribing an antidepressant or antipsychotic. Keep in mind that glucose and lipid dysregulation can occur even in the absence of significant weight gain. And lower your threshold to intervene as the number of risk factor increases. For example, if a patient is having a strong family history, he is obese, he is having signs of insulin resistance, this is a high candidate to develop diabetes when you put on some high metabolic risk medication. Next. So these are the drugs which are implicated in weight gain, risk of diabetes and worsening of lipids. For example, clozapine, olanzapine, risperidone and quetiapine. And how do you follow? This is a chart. That how do we follow if a patient is at all being given these drugs by family history, when to call in for his weight measurement, waist measurement, blood pressure, when do you assess his glycemic control and when do you assess his lipid profile. Next slide. Now this is the last slide and this is very important which we often get a reference that is the psychopharmacology and endocrinopathies. The drugs which we use in psychiatry department which may lead to some endocrine dysfunction. First, we all know of the drugs which leads to hyperprolactinemia, SSRIs, antidepressants, antipsychotics must be kept in mind. One of the drugs, risperidone, can increase prolactin to the tuberous range, that is more than 100 units. That should be kept. Recently we dealt with a patient. I suspected that the patient her prolactin was very high. So I was surprised and then we sat with a psychiatric colleague and we then look back into the prescription the patient has been having and there was the mention of risperidone the patient was having. So this was it, you remove this and the patient needs no treatment for it. Another which we have talked about, the antidepressant and antipsychotic leads to glucose derangement and obesity. Next, hypothyroidism, lithium, we all use. It's an agent which hampers the release of thyroid hormone from the thyroid gland and therefore must be kept in mind when the patient is on lithium for a long time. Second, again the side effect of lithium or lithium intoxication is hypercalcemia. Second, metabolic bone disease. This is something which is new coming on. We use anti-epileptics and all anti-epileptics have a role in creating osteomalacia and osteoporosis. So if a patient has been on carbamazepine, phenobarbital, phenytoin, valproic acid for a long time, take care of supplementing vitamin D and calcium in this patient. Next, last is SIADS, that is syndrome of inappropriate ADS secretion. SSRIs and tricyclic antidepressants are known to cause this syndrome. Must be kept in mind if the patient is entering into the emergency department with psychosis, multisensorial seizure activity. Thank you very much for your time.
Interest to all the clinicians, whether physicians, neurophysicians or psychiatrists. I invite the queries from the audience. Dr. Amit will be kind enough to answer.
What used to be called stress diabetes earlier. Some kind of psychological stress, the patient is undergoing stress in his life. Diabetes is precipitated. And it was believed that when the stress will be over, the diabetes will also increase, blood sugar levels will also fall down. So this is the same sort of thing.
It is a combination of having an increased chance of diabetes and diabetic being depressed. It's an umbrella statement. It needs a comprehensive management, just not the prescribing antidepressant. This is what stresses.
Doctor, practicing psychiatry. आपकी बात बहुत अच्छी थी, पर मैं 2 पॉइंट्स को बस ऐड करना चाहूँगा जो हम लोग प्रैक्टिस में जल्दी देख रहे हैं. Number 1, patients, because life expectancy has increased, so more and more of the adult population, and especially senile age group, we are seeing dementia cases. And they say for every case of dementia, you should go for thyroid examination, like 3 to 4 cases, because some of the cases are there where you got hypothyroidism plus dementia. You can treat them and the fellow will get the desired benefit. Second, about the obesity. Generally, people in the medicine branch, they are ordering for cholesterol examination. Suppose cholesterol is high, they are giving anti-cholesterol drugs. Some of our patients who are suffering from schizophrenia and depression, somehow I don't know how their metabolic disturbance is there, but somehow depression and schizophrenia gets worsened after using anti-cholesterol drugs, some of the drugs. Third point is in cases of depression treatment, when we are giving antidepressant drugs, sometimes with based on the drugs, based on the counseling, based on the psychotherapy, patient doesn't improve. And some are senior psychiatrists, they are adding low doses of thyroxine plus antidepressant. So have you come across any such type of patients or any such type of treatments in psychiatrists in collaboration with physicians and patients?
Thank you, sir. I mentioned in my slide also. Regarding that is anti-cholesterol drug, that is statins or fibrates which we use in patients who are having a dyslipidemia, we have certain guidelines formulated when to use and when not to use. Some of these drugs are enzyme inducers. Might be they are handling with the drug you are giving for a psychiatric manifestation and is reducing thyroid functions which are normal. In an elderly patient, levothyroxine have no role. In fact, it can be detrimental to the patient and has been shown with great documented evidence-based medicine that elderly patients who are given excessive dose of levothyroxine, so much so that their TSH is suppressed and they are made iatrogenic thyrotoxicosis, will have more of an heart disease, cardiovascular mortality and osteoporotic fractures. So that is something which does not go hand to hand, and for depression in diabetic patient not including antidepressant and levothyroxine.
Yes, medicine. So kindly explain about the 5-alpha reductase inhibitors.
That what I was telling you. That's a passing if the brain get reduced by 5-alpha reductase. This is the same molecule which we could give for this BPH, benign prostatic hyperplasia. That has been described. So this is, I got a passing reference. I just want to show an insight to you people that you go and see whether it's being of benefit or not. It has been given for affective disorder, Tourette syndrome, like this.
Your heart case. The patient is having history of 1.5 year history of psychiatric manifestation in the form of depressive symptoms and auditory hallucination. And the patient was treated by different psychiatrists with psychotropic medication in the form of antipsychotics and antidepressants and not responded to treatment. And subsequently the antipsychotics were withdrawn. And the patient is having some agitated, violent behavior off and on, and having depressive symptoms off and on, and ultimately he was referred to the Department of Medicine where the baseline thyroid assessment is done, and the thyroid level is found, TSH level is found to be 100 each. So there is that. After that, he was given 100 micrograms of thyroxine. And after giving thyroxine, the symptoms of psychosis flare off. And probably this is the reason we have given explained. Initially, high dose of thyroxine supplement will flare off the psychotic symptoms. And again, she was referred to the Department of Psychiatry. And subsequently, we have added haloperidol and his agitation and psychotic behavior control. And further, we have assessed the thyroid function test. And still the thyroid profile is deranged. And again, after consulting the endocrinologist, we have increased the dose to 125 microgram of thyroxine, and the person responded well. So probably because of sudden increasing the dose of thyroxine, the psychotic symptoms cleared out. Thank you, sir, for that.
Thank you so much.
and I wonder if he could have added a slide which said that on initial assessment of depression and initial assessment from psychosis, what are the screening tests that we must do? Because sometimes a clinical diagnosis or clinical signs may not be so obvious, whereas a simple test of TSH or electrolytes can reveal a lot more and a lot earlier and in time. Congratulations. Thanks.
The TSH, how do we rule out a person who has got, just now you have mentioned about memory loss, is it not? And it has been found that the person had, in fact, increase in TSH. But just now you have mentioned also, if a person is having memory loss and if he is being given TSH, the thyronorm or whatever, he can undergo problems. So there are three things I am trying to relate. Number one is hypothyroidism, memory loss, and number three is the obesity. So three things are there, all related in a person, elderly person. How do you treat him?
Reason is how over hypothyroidism, you ought to treat that patient. And if the TSH is on the higher side of normal, you want to give the benefit of drug to the patient, like levothyroxine will improve dementia. That's not okay. You have to be very careful when you are prescribing a drug, especially levothyroxine in elderly population. Very, very, very careful. It can aggravate an underlying cardiac disease and you will land up into trouble. As far as obesity is concerned, a lot of things is going on. That is obesity. We usually get a thyroid function test done. One thing is that you don't have an increase in weight of more than 10% of your ideal weight if you are hypothyroid. In a morbid obesity, you get it done. We all get it done, and you get a TSH of say 6 or 7. That is subclinical hypothyroidism. So that's not. That is the body's mechanism to deal with obesity. The thyroid excess, it responds to the obesity because adipose tissue itself is an endocrine gland. It produces so many hormones. Leptin, there is resistant, there is interferon alpha, there is TNF alpha. They do something abnormal to the thyroid excess and causes an increase in the TSH.
So till what time?
Hypothyroidism, and there are guidelines which tell us that when to treat these patients or not. Just to summarize them, a patient who is having underlying Hashimoto's thyroiditis, or that is entire scenario of subclinical hypothyroidism, in pregnancy. In pregnancy, if the TSH is slightly high, we ought to treat. If the patient is having menstrual irregularity, infertility, we ought to treat. So these are the few conditions in which we give or replace thyroid hormone, and this is well documented. Else, it is just clinical in your judgment.
And I really thank the Department of Medicine because one of my relatives has been cured of hypothyroidism, and he was actually around 98 kg. He had some psychiatric problem also, and after treating his hypothyroidism, he has lost 18 kg of weight, and he has, in fact, all congratulations to the team effort of the whole department of psychiatry, endocrine, and leukemia and psychotic picture.
Although there were no endocrine disturbances, but it's like any activity to the water filters, the type of water, especially in the elderly, they are more prone to hyponatremia because they extract all of the sodium, and it's not recommended that they should also mix water from the tap also, that is contain the normal. So hyponatremia without any endocrine disturbances. Secondly, there was a report, if a diabetic patient, he had a suicidal tendency. He had a very effective module in the hand. He can commit suicide. So it can take a lot of anti-hypoglycemic drug to commit suicide. So suicidal tendency in a diabetic patient should always be assessed. And thirdly, regarding your experience, we'd like to ask the role of anabolic steroids and testosterone, especially in the patient who are not having any deficiency.
Equal to that of menopause, but may never have andropause. Guidelines are clear. We have to take the symptomology of the patient, the assays with the testosterone. Now testosterone have a problem with the assays. It is total testosterone, bioavailable testosterone, free testosterone. These complicate the things. It's a grey area in which we are working upon. We don't give those patients straight away that those who are having a normal testosterone being depressed, it's because of andropause. the point is well taken, but it's still a grey area. Guidelines are there, but guidelines then are guidelines. Whether to follow them on your patient is entirely your clinical experience.
Dr. Ravi asked over that. They have pseudo hypoparameter. You get a CT done and you have multiple classifications and the patient is borderline. I wanted to know one thing. There are few patients of the old age who have a recurrent hyponatremia, and there is an entity known as recurrent hyponatremia. Persistent hyponatremia they call it. What could be the cause?
The causes of hyponatremia are innumerable.
My question is very simple. Hyponatremia in old age.
Hyponatremia in old age.
Recurrent. Rather persistent. Give them sodium. How long you can give them sodium? Don't find any cause. We have consulted endocrinologist, we have consulted nephrologist. They said that we don't have anything.
Fixed hyponatremia. And the two things which we want to rule out is hypothyroidism and adrenal insufficiency, and then we entertain the diagnosis of SIDH. And the causes you may be able to find out, you may not be able to find out. A drug of latest development available is onivyeptan, which can be given to these patients, and unfortunately is not available in India. Sooner it will be. So this is the V1B antagonist and decreases the production of ADH and will be helpful in these patients. What is the
Communist side effect?
My experience is not much because I have not used it in the clinic. It's just only a theoretical part which I am covering.
So I want to discuss about the basic complaints of weakness of the generalized weakness. After the अंदर हो जाता है ऐसे there can possibility of cirrhosis. There is a chronic conflict with in-laws. The person is having chronic conflict with in-laws. And we have taken the emergency and I have taken the history and while measuring the blood pressure, when I raised the blood pressure, I saw that there is carpopedal spasm. So I have kept a possibility of hypocalcemia. And immediately referred the person to assess the serum calcium level. It's found to be very low, 0.4 or 0.5 level. And again we have referred the person to the dermatologist. I think that the person may have some conflict in the families and may have some stressor, but it's not essential that the stressor will produce the symptoms are physical. Because of those stressors, the physical symptoms are improved.
It can be the other way. These hypocalcemia can lead to a patient having these conflict with
Maybe
specialties are the two branches which are coming closer, and more research, more insight into this, probably we will be able to treat these conditions in a better manner in future. Thank you.
And I would like to thank our chairpersons. And may I request Dr. S.P. Gupta, General Secretary, IPS Central Zone, to present a memento to our speaker, Dr. Amit Rasto. Thank you, sir. Thank you, sir. May I request Dr. Unni to present a memento to our second chairperson, Dr. S.P. Gupta. And D.K. Dalal, Professor and Head Department of Psychiatry, KGMU, Lucknow, to kindly chair the second session. Dr. Dalal is an eminent psychiatrist and an outstanding teacher. I invite Colonel Alok Anand, a senior psychiatrist who served in several important military hospitals and is a revered PG teacher and presently posted at Military Hospital Meerut, to kindly chair the second session. The talk in this session is by our eminent guest speaker, Dr. Prabhat Sithole, the Prof. from Psychiatry.
I
I would say, my guide all through my career. And what do I say as a psychiatrist? And throughout his career, he practiced child psychiatry and only child psychiatry, although with great difficulty we could involve him in adult psychiatry. So this is the introduction. I will not come in between you and Professor Sitwale. Sir, please give us your talk. And the topic is recent trends in management of disruptive behavior disorders, including IPS. Sir.
Now, yes. I think my presentation is being uploaded. In the meanwhile, I would like to thank Professor Subharti and Dr. Subharti for inviting me here and speaking to you about management of disruptive disorders. ADHD, or also known as hyperkinetic disorders. And then these are two other conduct disorders. Now, oppositional defined disorder and conduct disorder are together also known as conduct disorder. And there's been some controversy whether oppositional defined disorder is a minor kind of conduct disorder or whether this is a separate diagnostic entity. Well, in ICD-10, ADHD or attention deficit hyperactivity disorder is known as hyperkinetic disorder, and ODD and CD together are known as conduct disorder in ICD-10. Well, the main problem with disruptive disorders are that these disrupt peaceful and harmonious settings and disrupt the functioning of others. May I have the next? The aim of this presentation is to provide a very brief description of clinical features, the course and outcome of disruptive disorders, very brief comment upon etiology of disruptive disorders so that the management becomes more understandable, and the rationale behind the management, and then talk about the pragmatic management of disruptive disorders in clinic, home, and school. The next one. In ADHD, those who have a psychiatric background would know about this, but for those who are not from psychiatry, this is a condition in which children or anybody, a person has excessive, developmentally inappropriate inattention and hyperactivity and impulsivity. And this condition is pervasive and is impairing, and it is not due to any other physical or psychiatric disorders. If such a condition persists for something like 6 months or more, you say that this is attention deficit hyperactivity disorder. And typically ADHD starts during childhood. The next slide. Now, what is hyperactivity? This is quantitatively excessive movement. Impulsiveness is acting without thinking, and inattention is lack of sustained attention, lack of attention to detail, short sequence activities, changing before completion, and disorganized and forgetful behavior and distraction. Other behaviors associated with ADHD are irritability, flaring up of emotions on provocation, poor sleep, aggression, and non-compliance. Sometimes these children could be humorous, inquisitive, and intuitive. It's a lifespan disorder, which means that once started during early childhood, this could continue through adolescence into adult life. So there is something like adult ADHD also. It has a high comorbidity, the highest being with disruptive disorders like ODD and CD, and there could be mood disorders, there could be disorders of specific learning disorders and things like that. And the presentations of ADHD, they change over time. So the kind of presentation that you see during early childhood may not be seen during adolescence, and then in adult life the presentations change once again. ADHD causes lots of impairments, and these are accidents and injuries, there are educational problems, there are social problems, there is greater prevalence of tobacco, alcohol and other substance abuse, there is high risk of sexually transmitted disorders, unplanned pregnancy, there is more traffic rule violations in ADHD, and the medical costs are increased. We'll talk briefly about the etiology of ADHD. ADHD's etiology is, there are two kinds of etiology. One is pathophysiological and psychopathological. For ADHD, pathophysiological etiology is more important, and this helps us in treating this condition. Genetic and neurotransmitter factors are strongly implicated in etiology of ADHD. Behavioral inhibition is one central feature of lack of behavioral inhibition is one central feature of ADHD, and this leads to impairments in motivation and arousal, delayed gratification, working memory, and self-regulation of affect. There are problems in accurate interpretation of non-verbal social cues of others and in social situations, and this results in frustration for ADHD children, and this results in their aggression. For assessment of ADHD, it is suggested that we use multiple informants. Take information from the parent, from the child, and also get a feedback from the teacher, because it is possible that children might behave differently in different situations. Assessment of the child's intelligence and his psychological development is essential, because you do not make a diagnosis if a person has got a very low IQ, because then it is possible that his inattention is explained by a low IQ, or by specific learning disorders, or if his restlessness is due to some physical disorder. Then for screening and diagnosing these cases, it would be best if you use semi-structured interview schedule like the schedule for affective disorders and schizophrenia, present and lifetime version. And this also helps to diagnose comorbid psychiatric disorders. Then I suggest use mental status examination for diagnosis of ADHD, because if you are relying only upon history, then it is possible that you might be making mistakes. It is possible that a child has got, say, a specific learning disorder, and because of a specific learning disorder, he is unable to focus on what is being taught in the class. So unless you see for yourself the child's restlessness, his inattention, his impulsivity, the diagnosis may not always be correct. severity of ADHD could be judged by using a rating scale. Impairment is also important to find out that the symptoms are impaired. And this could be done by using a rating scale known as Children's Global Assessment Schedule. Make investigations and referrals if required to rule out physical disorders. Assess in multiple sessions and settings which are appropriate to the child's development. Collect all information, consider differential diagnosis, physical disorders, drug side effects. Say for example anticonvulsants. When they are given to children, in 30% of cases they can cause inattention and behavioral problems. So this might be confused with ADHD. Then environmental toxicity and psychosocial under and overstimulation should also be a consideration. A child who is very bored, left on his own, act in a manner like a child with hyperactivity, or he might be inattentive. Similarly, if the child is overstimulated, he might also have symptoms of attention deficit disorder. Now, I have talked that pathophysiological factors are important, and when you talk about treatment of ADHD, then psychoeducation should be the first step. Unless you psychoeducate the parents, the child, and if possible teacher, you may not be able to get the optimum results. And it's important to talk to the parents about the disorder. Then in general, psychological treatment can be considered for those individuals who have mild disorder, and medication should be reserved for those who are not responding to psychological treatment or who have moderate to severe disorder. But it is ultimately the patient's or the parents' call as to which treatment should be started first, medication or psychological treatment. And we should also get to know about whether the child has been treated previously and what has been the response to treatment. The next one. If you are doing psychoeducation, explaining to the parent, the family, and to the child what the problem is, then you develop a therapeutic alliance. It is essential for treatment. And then after that, having done all those things, you have to make a comprehensive, individualized treatment program. It's important that in psychoeducation the parent recognizes that ADHD is a chronic disorder and not ordinary childish mischief. And then it's important to find out which are the target symptoms. For the parents, say the target symptoms might be different from symptoms of attention deficit hyperactivity disorder. Then observation and rating of these symptoms should be done based on some existing rating scale which I mentioned before, or you could make a rating scale of your own in consultation with the parent so that they find it easy to grade the progress of the child. Then there should be an agreement on follow-up, how soon we are going to call the patient. Sometimes initially when the dose is being set, a weekly follow-up might be required, and later on fortnightly or monthly, and then 6 monthly like that. Then when you are using medication, your support should be available to the family for development of side effects. You might get calls if the child is not responding or he is having certain such side effects to medication. You should be available to responding to those things, otherwise the family may disengage and you may lose the child in your treatment. Then some kind of advice is necessary to the parents and to the child about the child's improvement in academic and behavioral functioning. And then you have to help the parents to anticipate the problems the child can get into due to his developmental challenges. For example, a child who is going to a new school is shifting say from primary school to a secondary school, or he is visiting other people and such things. When you psychoeducate the child, you have to make them understand that the parent, you have to make them understand the biological basis of ADHD, and you can explain to them about the efficiency of dopamine or norepinephrine in the frontal areas of brain, and this sort of medicalizes the problem. When parents understand that their child has got a disorder in which there is some definite physical change in the body for which medication is required, they accept it better than if you say that this problem is purely psychological. They should understand that ADHD is a chronic disability. You have to talk to them about the effects of medication. Medications like the stimulants, they have a short lasting effect, lasting a few hours. So a father who might see a child in the morning before the starting or effect of the stimulants might see him again in the evening when he comes back from the office, and by that time the effect of the stimulants is over. So the father, if he is coming to you, he might say that I find no difference in the child. But if the child is seen more often during daytime, somebody who is seeing the child at that time will find a difference. Then psychological treatment for improving the children's motivation. ADHD children have no motivation, they do not make consistent effort, so some help in this regard is also required. And warm, harmonious interpersonal relationship is advisable for families of ADHD, and the parents should be giving effective instructions. And when we say effective instructions, we mean that parents should say what is to be done rather than what is not to be done. So instead of saying don't run, the ADHD children run a lot, you say please stay quiet, please sit quiet, and say this thing when you engage the child's attention. So such things need to be taught to the parents. Follow-up of the child's actions is important. Then value of appreciation, the value of rewards and loss of rewards is also important. And then you need to talk about cases with good outcomes. For example, we can tell that some famous people, like say George Bush, both the father and son, they had ADHD and they went on to become president of the United States of America. What about some film actor who had ADHD like William Robbins? If we talk about such people, then the parents understand that despite their child having ADHD, he can develop and become somebody useful to society. If they are able to control the stimulation in the classroom and help the child to learn in small bits and allow him activity from time to time so that the child is less disruptive in the class. If the children are able, if the teachers are able to understand this thing, management of children with ADHD becomes easy. The next, if the above psychoeducation, common sense advice is not enough, specific treatment like behavioral therapy or medication or both may be needed. Medication, if it is effective, is enough. You treat children with ADHD medication, if they are treated well, if there is good effect, you will not be able to distinguish between a normal child and a child with ADHD. If it is only partly effective, you will have to add behavioral therapy. So if behavioral therapy is to be used, intensive behavioral therapy must be used. And this is all behavior therapy for ADHD is based on ABC of behavior, whereas A is antecedents of the behavior in question, that is the child's inattention, hyperactivity and impulsivity, and C are its consequences. So if you alter A or C, you can alter B. So that is the basic principle of behavior therapy. Then in behavior therapy, the rewards, that is you are giving some kind of reward or encouragement to the child, maybe it is social praise or some kind of material thing, then it should be given immediately. Similarly, for doing what you don't want the child to do, his reward should be taken away from him. But this loss of reward, the response cost and giving of reward, this should be done immediately after the behavior. If this is not done within a few seconds, it will lose its effectiveness. If the children are controlled with medication, but still they continue to think very low about themselves, we will have to think about some kind of psychotherapy. And the psychotherapy which is used most often is cognitive behavior therapy. And this is used for things like low self-esteem and procrastination. Now we shall come to medications about ADHD. We will talk about medications which are available in India currently. And these are two approved medications. One is methylphenidate, immediate release type and sustained release type, and atomoxetine. Atomoxetine first, this is a specific norepinephrine reuptake inhibitor. It does not produce dependence and is not a Schedule X drug. Now this is an important consideration because when the drugs are Schedule X, they are not available at all chemists. And then parents may have difficulty in acquiring or purchasing the medication. It is started at 0.5 mg per kilogram per day dose for the first 3 to 7 days and then raised to 1.2 mg per kilogram per day for about a month. If there is no response or inadequate response, you could hike the dose to 1.4 mg per kilogram per day, which is the approved dose, or you can go up to 1.8 mg per kilogram per day, which is not approved, but it can be used if you are an experienced person, and the maximum is about 100 milligrams per day. Those who have weight less than 70 kgs in children, this will be the usual case. You could start at 40 milligrams per day, raise to 80 milligrams per day after 1 week, and the maximum that can be given is 100 milligrams per day. Some adolescents could have weight over 70 kgs. Atomoxetine improves all features of ADHD. The effect begins in about 2 weeks' time and continues to improve for the next 8 to 12 weeks. So there is no point in very quickly enhancing the medication. The side effects include increase in heart rate and blood pressure, which is very, very mild. In very rare cases, there could be hepatic damage. This could cause hypomania or mania. But more commonly, there is sedation, fatigue, anorexia, insomnia, dizziness, anxiety, irritation, dry mouth, constipation, nausea, dyspepsia, and abdominal pain. And these could be managed by common sense management. It's an effective drug. Effect size is about 0.6, which is about something like medium to large, and the numbers needed for making a difference, NNT, is about 5. And in case of preschoolers, this is about 6. Atomoxetine should be used in children who have comorbid substance abuse, or if they have effect disorders or high levels of anxiety or insomnia. And those children who do not respond to methylphenidate, approximately 25% of them, they may respond to atomoxetine. And if the child is not responding to methylphenidate, atomoxetine could be added to it in a small dose. They will come to methylphenidate, which is the most effective medication, and its effect size is large, that is 0.9, and NNG numbers needed to treat is 3, and it has effect forms, but it can cause dependence and is a schedule X drug. The dosage, either you can give as 2.5 mg to 5 mg per dose in 2 or 3 doses, or you can go by 0.3 mg per kilogram per dose. And you could increase the dose by 0.1 mg per kilogram per dose, or by 5 to 10 you are setting the dose. The usual dose, an average dose at which children respond is 0.5 to 1 mg per kilogram per day. And the maximum is 0.7 mg per kilogram per dose, or 2 mg per kilogram per day, or up to 90 milligrams per day. If it is given 30 to 45 minutes before meals, the drug acts better. Methylphenidate has got hepatic metabolism, and it doesn't cause inhibition of CYP450 enzymes. That begins in about half an hour and lasts for something like 3 to 4 hours. We are talking about immediate release tablets to 8 hours. Recently a new product has become available which they say its effect lasts for 8 hours. So for an average child, you will need to cover something like 12 hours in the child's daytime. So we require 2 or 3 dosing for this drug. It may be effective in those 25% cases who are sometimes headache. It is best for you to wait, let the family understand that if they waited, the tolerance will develop. Or you could use a different psychostimulant which is not available in India, or you can shift to atomoxetine. For anorexia and weight loss, over-the-counter preparations could be used, or you could go beyond the effect of methylphenidate. That is, I said that effect of methylphenidate lasts for something like 4 to 6 hours. So if anorexia is caused because of it, you could give food after say 6 hours or before the onset of its effect. If tics develop, tolerate the situation. If it is a single trick, if it is multiple tics are there, one could add clonidine, which is another drug for management of atomoxetine, for management of ADHD and for tics. Or alternatively, one could use atomoxetine. If you have irritation, reduce the dose. If you have anxiety, reduce the dose. Use sustained release preparations. If the child becomes very frozen, sometimes when you give methylphenidate, the children's activity level is very drastically reduced, and they appear as if all activities frozen. This is something which frightens the parents. And then by reduction of dose, or by using a sustained release preparation, this problem can be taken care of. Then if these are the main frontline drugs are not working, one could use other medications which are available in India, which are treatments but not really approved medications. And these are bupropion, which can be used as something like 150 milligrams per day. The maximum one could use is 300 milligrams per day. Or one could use imipramine or norepinephrine. But you have to be careful in use of these drugs. These are tricyclic antidepressants, and these could cause cardiac damage in children. Clonidine is a drug which we sometimes use in management of children, and this is started at 4 microgram per kilogram per day, and the maximum which is given is 8 microgram per kilogram per day. The maximum for children under 40 kg is up to 200 micrograms per day, and for those between 40 to 45 kg, it is 300 milligrams per day, and for those over 45 kg, one could go up to 400 micrograms per day. Then modafinil is another drug. You know, it's an alertness promoting drug, and it can be given up to 50 to 100 milligrams per day. ADHD is associated with large number of comorbidity, and if you are using methylphenidate and atomoxetine, these might have effects upon the comorbid problems. Like methylphenidate reduces aggression, depression might improve. Otherwise, you have to use psychosocial treatments for comorbid disorders. If you have other conditions like anxiety disorders or OCD, you will have to use a specific medication for that. If ODD and CD are associated, then for them additional psychosocial treatment will be required, about which I will be talking to you shortly. Next one, please. The next one, please. After this, the next one. Yeah. We shall talk about oppositional defined disorder and conduct disorders now. The central feature of oppositional defined disorders are that there is conflict with authority and the child perceives threats to control and autonomy. The children often lose temper, they argue with adults, they defy or refuse adults' requests and rules, they deliberately annoy and blame others for the mistakes. They are very touchy, easily annoyed by others, they are very angry and resentful and spiteful and vindictive. It should be considered that such behavior is not due to any other physical condition or psychiatric disorder like psychosis, mood disorder, or antisocial personality. And the symptoms should be impairing to the child's academic, social, or occupational situation. And in conduct disorder, there is a difference from oppositional defined disorder in that conduct disorder is antisocial. And this is a persistent, recurrent behavior which infringes the rights of others, and it disrupts their peaceful and harmonious functioning. These are more than ordinary childish mischief, and examples are aggression to people and to animals, destruction of property, deceitfulness of theft, and serious violations of rules. Then when we consider etiology of oppositional defined disorder and conduct disorder, we find that psychopathology is more important than pathophysiology. Although from a pathophysiological point of view, there is a genetic evidence that such conditions run in families. There can be an aggregation of cases in the family. There is an association of ODD and CD with difficult temperament. Now children, when they are born, say in the first year of life, they could be broadly of two kinds. They could be easy to handle children, or they could be difficult to handle children. Those who are difficult to handle are more likely to develop a psychiatric disorder in future. And those who are easy to handle, they go on to become normal children where behavior is adaptive. ODD and the CD children develop a hostile perspective due to early negative experiences in their life. Their temperament is difficult, and in order to control this difficult temperament, the parents use coercive methods. They use force. And because of these negative experiences, they develop a pattern of behavior which can evolve into conduct disorder later on. And these children, they use socially relevant information less. Whatever is happening in the environment, they see only what's happening is negative. They don't consider what things are happening in a positive manner. And because they selectively think of only negative things, their behavior is also in accordance with that. That is, their behavior becomes aggressive or antisocial. When OD and CD children are, behavior is more driven by rewards. That is, what they can get, what pleasurable things, what sensations, what new things, what novelty they can have from the environment. This is more important for them. And their behavior is driven by that. And they are not deterred by what will be the adverse consequences of their behavior. So this is one very important thing which has to be used in management of conduct disorders. Then low socioeconomic status, family stresses and dysfunction such as poor parenting, parental discord, domestic violence, low family cohesion, child abuse, maternal depression, parental substance abuse and antisocial personality disorder. These are also associated with ODD and CD. Naturally, we can see from this that medications are not going to be effective for these kind of things. And for these kind of things, psychological and social treatment will be required. Then negative reinforcement result in the coercive parenting and the child's oppositional and defiant behavior. I would like you to understand this thing. Supposing a child is making some fuss, or he is doing something, he is not complying with the adult request. The father has said that go and study. The child is continuing to watch television. The father shouts at him and goes or hits the child. And then the child stops doing whatever he is doing and complies with the father's request. So in this case, the father's behavior is reinforced by happening that the child has stopped doing whatever he was doing. And as the child increases in age, he becomes older, and as he becomes older, the times come when he is unable to take things no longer. And when the father shouts or hits, it doesn't make any difference to the child. He even shouts back or hits the father or breaks something. Or that quietens down the parents. So in this way, the parent and the child, they negatively reinforce each other's behavior. There is something which needs to be taken into account in management of these things. Next one. I have said that biological things are not very important in management, so we will not talk about them. The next one. The next one. We shall talk about the protective factors. What are the factors which protect a child from developing conduct disorders or oppositional defiant disorders? If there is a loving family, there is a pro-social and intact family, a cohesive family with normal parenting and with consistent and rational pattern of disciplining, with average resources, that is, they are not poor, then such a family would not be considered at risk for ODD or CD. And a child with average IQ who is resilient by temperament, has an easy temperament, is attending a normal school, not a school which is known for antisocial behavior, then there is a possibility that this child will not develop oppositional defiant or conduct disorder. And if the neighborhood of the child is pro-social and without substance abuse and criminality, and there are no marked social contrast in that neighborhood, then the chances are that conduct disorder and ODD will not be there. So in your management, you have to reduce the risks and improve the protective factors. And this can only be done by psychological and social means. In assessment, like in ADHD, use multiple informants. You can only, depending upon the information by the parent, then you may get information about what the child is doing is bad, but the child might have other views about it. Or the child may not have bad behavior at a school. Then a timeline should be made. Now this is important for finding out which disorder has started when. These disorders have got large comorbidities, so it's important to know which has started first. Then IQ should be measured as in ADHD, and Connors rating scales could be used for quantifying or rating the child's behavior. And the children's global assessment schedule could be used for rating impairment. Now, all these scales can be had from the Department of Psychiatry, KGS. In management of these children, it's important that you elicit not only the weaknesses of the child, his bad behavior, it's also very important that you elicit his strengths. And there is an instrument called the strengths and weaknesses scale. Now this can be obtained free from the net. And what I wish to say is that if you talk about the child's positive points, you are better able to connect to him and to the family, and they'll become more receptive to you, and it will be possible for you to develop a rapport with them. Then, as I said, that psychopathological factors are more important in management of these disorders than pathophysiological ones. But the treatment is typically long-term. It is not like giving methylphenidate and ADHD symptoms are immediately controlled. The average time of treatment would be something like 2 to 5 years, and the treatment has got to be multimodal. Several kinds of treatment in several domains are to be applied intensively, that is from daily to weekly and concurrently, simultaneously. And these should be applied in multiple settings, that is at home, in community, at a school. Unless these things are done, the child is not likely to improve. If you are only improving the child's behavior at home, and if he continues to behave badly outside home and at school, then improvement will not happen. The treatments of oppositional defiant disorder and conduct disorder are very similar, except that the number of treatments applied are more for conduct disorder, which is a more severe condition. Then, like in ADHD, psychoeducation of the disorder is the first step, and you have to engage the family and the child and have a rapport with them. And then what I say might surprise you, that for early symptoms of oppositional defiant disorder and conduct disorder, primary prevention is the best treatment. Primary prevention is the best treatment. This is typically started, say, in early phases of life, say between 2 and 5 years of age, when the child has got problems like overactivity, he is non-compliant, he shows temper tantrums. If you are able to tackle the child at that point in time, you might be able to prevent the progression into a definite ODD or CD. Even at that stage, this kind of primary prevention is to be continued for something like 2 years. And the treatment is done at school or in community or at home, and the child, parents and the teachers are targeted for this treatment. The children are psychologically and socially stimulated by developmentally appropriate education. This is important because some children might be less able, and because of their high age, they might be taught at a higher level, which the children may not understand, and this could result in problems. So it's important that children are given developmentally appropriate education. They are treated with play and they are taught socialization. They are consistently and rationally disciplined. They are trained in cooperation and not resorting to aggression. They are systematically rewarded for positive behaviors by social praise. Their daily life is structured and regulated. They are trained in activities of daily living. The parents are taught in parenting skills. I said that their parenting is not very good, and they are encouraged to read and tell stories to the children and to play with the child, train him in activities of daily living, and apply discipline consistently and rationally. The parents are trained to observe positive behaviors of the child and appropriately reward them. Because what happens in such families is that the parents only look at the negative behavior of the child. They think that the child is bad. So everything which the child does becomes bad. When they learn to observe the child carefully, they are able to distinguish between the positive and negative behaviors. And it is the positive behavior that we have to target. In etiology, they said that these children are driven more by reward than they are deterred by punishments. So if you are improving or encouraging their positive behavior, they may change. But if you are punishing them, they are unlikely to change. If parents could be supported by visits to home by some member of the mental health team, then this is better for the parents. And in India, ICDS could be a program like this. Integrated Child Development Services. This was thought of as a program which will help the children in their psychosocial development. Whatever limited experimental evidence that we have from the work that is HMC, with the Department of Social and Preventive Medicine, and in psychiatry, it has been found that ICDS does improve children's behavior. Now, once you apply such behaviors to children who are, say, between 2 and 5, and for something like 2 to 3 years, then such programs, wherever these have been done, this has shown that benefits last even after these treatments have stopped. So you applied the treatment, say, between 2 to 5 years of age, you stop the treatment, but you found that benefits persisting up to 20 to 25 years later. When you follow up that cohort, you find that in them there is less criminality and there is less conviction, which is an evidence of improving children's behavior. Now, if you have established ODD and CD, then whatever we do, the psychosocial treatment or medication, if you are able to use, then it is only palliative and not curative. So the behavior is only partly modifiable. If you are acting between 2 and 5 years of age, the chances are that the children may recover completely. But after that, the treatment is only palliative. And for doing this, you have to apply treatments which are empirically, experimentally validated against appropriate controls, and these are directed at appropriate psychopathological processes. And these psychological processes, pathological processes which are considered important for management of these children are coercive family processes, about which I talked just now, and problematic parent practices. And these are the parents, they don't care about whereabouts of the children. The child has left home, he has gone to school, whether he has actually reached the school, or has reached the cinema hall or is loitering about in the market, the parents do not keep of track. They do not keep track of their friendships, whether they are associating with antisocial people or with pro-social people. This is not known to the parents. And the children have deficient social skills. That is, they do not know how to make friends with pro-social people, how to interact with them, so they gravitate towards those people who are antisocial. As I said earlier, in coercive family processes, the child and the parent usually negatively reinforce each other's aggression. I talked about problematic parental practices. In social skills deficit, the child misperceives the neutral social cues. Supposing 2 or 3 boys are talking to each other and your child, who is having this problem, disruptive disorder, is standing there. He misperceives they are talking ill of him, or they are talking bad of him, or they are trying to hurt him in some way. So children with these problems, they misperceive what is happening in the social environment, and they perceive these neutral things as threatening, and they react aggressively. The next one, please. To modify the above, parent management training is required. You have to train the parents for something like 12 to 25 weeks. This is a long period, and you have to teach the child problem-solving skills, and you have to teach him social skills. Another treatment which is useful is functional family therapy. Here all the family members attend, and the therapist focuses on quality family interactions and communication patterns due to which the family is unable to effectively control the child's antisocial behavior. The effect size of such treatments is medium to large, and the benefits continue even after the treatment is stopped. I shall talk briefly about parent management training. The parents are taught the technique, that is how to take care of the child. They rehearse it and apply it at their home to the child. It is also possible that this could be done with the therapist, that is the therapist and the parent together. They are helping the parent to take care of the child. The therapist solves the problems encountered in therapy, and it is generally enough for children who are 10 or less. That is, if you are only using parent management training, then this alone may be enough for management of these children. So the topics that are taught are important. These are the background of the disorders, attending and ignoring, by which I mean that attend to the child's positive behaviors also, ignore their minor mistakes, use praise and positive reinforcement at home. Some kind of token economy program has to be developed at home, that if your behavior has been good, say for 1 day, 2 days, you will be given this reward. And then giving effective instructions, which I explained earlier. Then time out, like if you are behaving badly, you are taken off from something which you like. That is time out. And then response cost procedure, that if you behave badly, then your numbers are cut, your points are cut, and some of your privileges or rewards that can possibly be given to you will not be given. And then these children are to be helped with their homework. Some strategies have got to be developed. The parents have to be trained as to how the children could be made to do homework. And then using a whole school report card as to what the child has brought from school, that is seen by the parents, and the parents act upon that. If the child's behavior has been good at home, he is given more points at home. If his behavior has not been good at school, his points are deducted like that. And use of when then, that is when you complete your school work, then you will be allowed to watch TV. So the parents have also been trained in such kind of techniques, and the parents should be taught as to how they should control their children in public places. In child problems and social skills training is given for older children and for adults, who are explained about its rationale, and the child is helped to think of the problem situation and his usual social responses in the situation. I was saying that the child is helped to select an appropriate response, and then his effort is suitably reinforced. And when the child behaves better and he finds that he is able to function better, then a cognitive restructuring would be done for that child. And before the child goes out in real life, he is given practice in the clinic or at home situations. Anger management is another technique which is similar to this. Now, systemic therapy and multidimensional treatment of care, these are things which may not be possible in other settings. It was being talked about that we have very few psychiatrists and psychologists and trained social workers in this country. Both of these require teamwork. In multi-systemic therapy, the treatments are applied at the child's home and his community, then and there. And the therapists have got a very small caseload. They are looking after only one or two families. So whenever a question is asked by the parent or the family that such a problem has arisen, then the team has got to respond to it. There's something that is difficult to do in other settings. I wonder if it is being done anywhere in the country. And in multi-dimensional treatment foster care, the child is placed in foster care. And the foster parents are those who are trained in taking care of children with disruptive behavior. So this is something, I do not know whether such a thing has been done in India in psychiatric setups or not. We have the next one. Multi-systemic therapy and multimodal treatment foster care are alternatives to the child going to jail or having long-term psychiatric hospitalization. In Western setups, this is an alternative to that. And results show that these therapies are effective and there is some reduction in reoffending. Now, as I said, that pathophysiology is not very important in management of conduct and oppositional defiant disorders, and there are no validated treatments for this purpose, unless ODD and ADHD are comorbid. If they are comorbid, their severity co-varies. So if you are giving methylphenidate to a child with ADHD who has got comorbid ODD, then his ODD is also likely to reduce. That is the only thing that could be done. Now, depression can be non-specifically reduced by use of antipsychotics, mood stabilizers, lithium, SSRIs, in case where there is comorbid anxiety disorders. Otherwise, pharmacotherapy has got no place in management of disruptive disorders, conduct disorder kind and ODD. May I have the next one, please? I will not repeat the summary because if I do that, light will again go out. Stop my presentation here. Thank you very much.
Most of the time we practice adult psychiatry, And now that the general public has been so poignantly made aware of, and when our both parents working and nuclear families, is even bigger problem. And for that reason, it's very important for us to continue to learn child psychiatrists and persons such eminence as Dr. Dole about current trends and treatment of such illnesses. I have the privilege of sharing the session, and he is the speaker. Otherwise, in Lucknow, I had always the privilege of sitting and listening to his very clear and concise comments, and he was mostly sitting in the chair for any session. With this, I request the audience to come up with any clarifications, comments, suggestions.
Very easy. Either of ADHD or CD or whatever. And very easy like normal. There is no indication of any epilepsy of any kind. Shall we add anti-epileptic or not? Second, there are few persons who in adult life have a residual ADHD. And I happen to cross patient with a doctor by profession. With atomoxetine he was feeling very well. Then he developed hypersomnia and he stopped atomoxetine. I tried to convince him to take some other drug which he refused. What is to be done?
You ensure that the compliance, how to manage it. First, I'll start with tobacco. Of course, there are many hard drugs which are probably more important, but I have chosen tobacco first of all because of various reasons. First of all, it's most common. It is as addictive as any hardcore drug like heroin or pethidine. Because it is socially sanctioned to some extent, people just ignore it, but it's probably more harmful. It creates more burden on the society rather than other drugs. So, gentlemen, ladies and gentlemen, about 30% of world's adult and adolescent population uses tobacco. This is the most common prevalent drug addiction. Illicit drug. It is not illicit drug, it's a illicit drug. I will come to the illicit later. So this is the most commonly abused drug. About 1.3 billion people around the world smoke. About 1 billion men and 250 million women. 6 trillion cigarettes are smoked every year, which comes to about 15 billion every day. And if the current trend continues, there will be around 1.6 billion tobacco users in the world by the year 2025. So it is very important that we should intervene. In India also there are 150 million men and around 44 million women who use tobacco, both in smoking as well as in smokeless form. Next. Why tobacco is addictive? In smokeless tobacco there are around 3,000 chemicals. Okay. While tobacco smoke has 4,000 chemicals which have been detected. Smoke has antigenic, cytotoxic, mutagenic and carcinogenic substances. 55 carcinogens have been detected in tobacco smoke, which are polynuclear aromatic hydrocarbons, aromatic amines, cytochrome P450 hydroxylates, such as the W-sequin, which is the carcinogen, very strong and very notorious carcinogen, and there are certain and nitrogen also. So these are the carcinogens which are present in tobacco smoke. Highly toxic gas, that is carbon monoxide, that is also there. Next. But what is a cause of addiction? addiction is caused by a very potent and very important chemical that is present in tobacco, that is nicotine, that is responsible for a number of pathophysiological changes in the body. This is an alkaloid, it is colorless, volatile alkaline, which turns pale yellow to brown after exposure to the air, and it is highly toxic and it is potentially lethal. And one drop of pure nicotine, if placed on the tongue of a person will die instantly. So this is so poisonous. And it is water soluble. And in the smokeless tobacco, it is dissolved in the moisture of the tobacco leaf. While in tobacco smoke, it gets suspended on the tar as a free ion and can easily pass through the blood-brain barrier. So that's why it is gives immediate effect to the smoker. When the smoker takes a puff, it immediately goes to the brain, and that's how it is. It tolerance to its own action, and that's why it is highly addictive. Next. So how to treat them? When a person willing to quit smoking, it comes to you, first of all, after which we have discussed the basics, after that you administer Packerstone's test. That is a scale, very easy scale, which quantifies addiction. So from there you can find out how much addiction the person has. One most important question to be asked from smoker, whether he is addicted or not, is when does he require his first cigarette after he gets up in the morning? If he wants the cigarette to be smoked within the first half an hour, it means he is strongly addicted. So that question itself will imply whether the person is addicted or not. So that will help us in treating the patient accordingly. So the pharmacological treatment is nicotine replacement therapy, bupropion, amitriptyline, clonidine, varenicline, and now the drug Nicfax that is still in the track. It is not formally launched and neither it has been approved. In behavioral treatment, we have aversion therapy, contingency treatment, and coping skills which are taught to the person how to deal with the symptoms. So in the replacement therapy, we have nicotine gums, nicotine patches, lozenges, solution, and sublingual tablets. Here in India, we have nicotine gums and nicotine patches. They are available. Other drugs are bupropion, nortriptyline, clonidine, and varenicline. All these drugs are available. Next. So how does nicotine replacement therapy help? First of all, it relieves the craving. Because nicotine is already there into the nicotine patch or in nicotine gum. But at a lower level than the smoker the level has. So at a lower level only it relieves the craving of the person. And at the same time it also looks after the withdrawal symptoms. And it also provides positive reinforcement to some extent. And of course, it also desensitizes the alpha-4 and beta-2 nicotine acetylcholine receptors which are sensitive to nicotine and gives a kick to the person at the time of stimulation. So that's how nicotine replacement therapy works. Next. Next is clonidine. Clonidine, as you know, it's widely used in various conditions, and it's a alpha-2 adrenergic receptor agonist, and it reduces the sympathetic outflow which results into sedation, anxiolysis, potential hypertension, bradykinesia, and dry mouth. These are the side effects. But the main effect here we want is the anxiolytic effect. It calms down the person. And probably that is the main effect which helps the smokers, because many smokers are anxious whether they are not confident whether they will be able to leave or not. In those patients particularly. It is quite next. Then there are certain antidepressants like bupropion and amitriptyline. They are found to be quite effective in various randomized controlled trials. Bupropion, which is a dopamine blocker, blocks the reuptake of dopamine and makes more dopamine available. And to some extent, it also blocks the norepinephrine uptake. So that is also available. And this effect is just like that of smoking. When the smoker smokes, nicotine goes into the body. There also there is dopamine release and norepinephrine reuptake inhibition. So their level is it acts the same way, and that's how it is helpful in de-addicting the person. Norepinephrine is a blocker of norepinephrine uptake and makes more norepinephrine available in the blood, in the intracellular blood, and that's how it helps. Next. Varenicline is relatively a new drug. It is in the Indian market for the last couple of years, and it is found to be effective in certain patients. That it is a highly selective activity at alpha-4 and beta-2 receptors. That is, affinity for nicotine. It acts at that level, and it's a partial agonist at that level. It's not a complete agonist. It doesn't act like nicotine, but to some extent, 30 to 60% it acts like nicotine only and makes dopamine and norepinephrine available. So at the lower level only it helps, and it also maintains moderate levels of dopamine and reduces craving and withdrawal symptoms. And it blocks the reinforcing effect of nicotine from cigarette smoking in these cases. So that's how varenicline helps. Next. This is something new which is not still there in the market, and it's still in the experimental phase. This is Nick wax. It stimulates the immune system of the body. And how does it help? That antibodies are formed because of stimulation of the immune system, and these antibodies get attached to the nicotine atom, making the nicotine atom quite big. And when it becomes bigger, it cannot pass through the blood-brain barrier. And when nicotine is not able to pass through the blood-brain barrier level, it will stay in the blood only, it will not reach the brain. And if the person who is smoking, he will not have the effect of nicotine at all. So that's how it is helping. This is the mechanism of it. But still it is in process, it is in preclinical phase, and that has been suggested that the injection or the vaccine is to be prepared. And that would be effective not only in helping to quit smoking, but it will also help in relaxed attention. Because the action of this is going to last for longer period of time. They say it could be up to 1 year. So once one injection will help the people to stay happy and don't smoke. It is yet to come. Next. So friends, this is the treatment chart for nicotine dependence. Treatment is divided to first line treatment and second line treatment. First line treatment consists of bupropion and nicotine replacement therapy in the form of nicotine gums or nicotine patches. Bupropion is available as a 150 mg tablet. For the initial few days, it is to be given once daily, and after that it is to be increased to twice daily for 7 to 12 weeks. This is the treatment regime for bupropion. When you start bupropion, you ask the person to decide a quit date, maybe after 2 weeks, because that much time bupropion takes to show its effect. And on the quit date, the person quits it, and after that, it has to be done. Nicotine gums, they are available in two forms, 2 milligram and 4 milligram forms are available. For those who are smoking less than 25 cigarettes per day, 2 milligram patch is 2 milligram gum is sufficient, and it can be given every 1 to 2 hours for the first 6 weeks, and after that 1 gum every 2 to 4 hours for the next 2 weeks, and then for the next 2 weeks 4 to 8 hours each year. So that's how it is the total treatment of allergy. Similarly, patch is also applied like this. There are 3 varieties of patches, 21 milligrams. It has got capacity to release nicotine for 24 hours. 14 milligrams, which is also having the capacity for release for 24 hours, and 7 milligrams. So, if the person is smoking more than 10 cigarettes, we start with 21 milligram patch, which is to be given for the first 6 weeks, then 14 milligram patch for the next 2 weeks, then 7 milligram patch for the next. So gradually you taper it off, so that it doesn't become dependent on these also, because that also contains nicotine. So you have to be careful about it. So similarly, the second line treatment that I have already talked, nonadine is one, generally 0.15 milligram is given, but it has got its own side effects like hypertension. You have to closely monitor blood pressure of the person, and it also causes depression. Nortriptyline is also effective. It is found to be effective in the dose range of 75 to 100 milligrams per day. Next. Now coming to alcohol. I am hopeful that the tobacco is quite clear. In case you have any questions, please note them down so we can discuss later. So alcohol is another problem, is an endemic problem right from the time of when the dawn of civilization was there. We find references in our historical books or even in the mythological books that your gods used to drink sura and somras, of course. So this is available right from the time of the beginning of the history. And even today it's a problem in general in the society. The National Household Survey, which was conducted in 2004, revealed that 21% of men and 5% of women in India use alcohol on a regular basis. And more than 50% of these qualified to be hazardous drinkers. So you can tell the gravity of situation. And studies have also revealed that Indian drinkers have more negative health events like accidents, like liver pathology or other comorbidities as compared to people counterparts in other parts of the world. Next. How is alcohol metabolized? Alcohol dehydrogenase is an enzyme which converts alcohol into acetic aldehyde, and there is acetic aldehyde dehydrogenase which converts aldehyde into acid. So this is a mechanism. It will be helpful to us when we talk about the treatment technology. Please remember that. So these are the blood levels. I think I should not go into the details of these because you must know that up to 100 milligram percent there is the incoordination of movements and the change in the behavior. Up to 200 milligrams you find ataxia, there will be zigzag walk of the person and the mental being impaired, and up to 300 milligrams the person may develop nausea and vomiting, and there will be severe dysarthria, you will be not able to speak properly, and there will be forgetfulness up to the 400 milligrams, up to 400 milligrams, and up to 600 milligrams he may go to coma, and up to 800 milligrams of course settle and there will be profound effect in the respiration and the blood pressure. These levels keep varying according to the tolerance. So how much tolerance the person has developed levels also vary. What should we do if the person comes in intoxicated? He is totally under the influence of alcohol and he is totally. What will you do? You examine the person first. The cardiovascular system and respiratory support is very essential at that very time. That you must provide. Start with the IV fluids, give thiamine, multivitamin, folate, and assess for other drug intake in case the person is taking other drugs like opiates, because they may be quite helpful in therapeutic intervention if you know that. Next. Then if the person comes in withdrawal, it is make it customary that you administer a scale so that you can monitor the improvement or the impact of the treatment on the person. There are certain scales which are used, that is modified selective severity assessment scale. It is applied for quantifying the severity of withdrawal. Then clinical institute withdrawal assessment scale for alcohol, that is also used. And these scales are helpful in monitoring the treatment of the person. Next. The common withdrawal symptoms are tremors, agitation, autonomic changes, seizures, and sensorial may be altered. They have confusion, hallucinations. These are the common withdrawal symptoms that we need to change. So the withdrawal symptoms commonly start within first 24 hours and last up to 5 days. 90% of the cases do not go beyond the first stage. I will describe what stage is subsequently. So 90% of the cases, if they are treated well, they will not go to the next stage of withdrawal. Other symptoms which may include are depressed mood, anxiety, headache, nausea, vomiting, etc. In stage, that was stage 1. So in stage 2, only those patients go which are either undertreated or they are untreated. The symptoms in second stage are the same with more severity, and hallucinations may develop in the second stage. Usually they occur after 48 hours. So that is the second stage of withdrawal. In the third stage next, in third stage that generally begins after 72 hours, releasing tremors develops, which is a acute reversible organic psychotic condition with 25% mortality. The person left inside gets a clouding of consciousness, there will be hallucinations, there will be disorientation, labile effect, and in such type of patients, we will begin with benzodiazepine therapy and be sure that these are just withdrawal symptoms and not the symptoms of intoxication. If you think that it could be intoxication, in that case, you get the blood alcohol level done, just to be sure of it. Next. So benzodiazepines, we use long-acting benzodiazepines like benzodiazepine or diazepam or oxazepam. Oxazepam is used only in those persons where there is a gross liver pathology, because oxazepam is relatively less hepatotoxic. Magnesium sulfate should be given in cases where there is a risk of seizure development. Intravenous fluids are given, supportive therapy in the form of intervening for hypertension, and in stage 3, withdrawal and management of other clinical problems. Next. When the person develops seizures, what should we do? In case of seizures, if the withdrawal in the first stage is not treated well, there are chances of development of seizures. Even for other causes, there could be head injury, there could be cerebrovascular accident, there could be CNS infection or anything of that kind. To work up for brain imaging, 1 out of the 4 cases who have developed seizure may have second seizure. So 25% patients may develop a second seizure, and that needs to be looked into. Less than 3% become status epilepticus, and increase this if prior seizure is there, or if you are treating benzodiazepines or sedative withdrawal. In that case, seizure possibility is more. Parenteral benzodiazepines like lorazepam 2 mg, that is short-acting, or diazepam 10 mg can be used. Anticonvulsants are generally not given in these patients unless there is sufficient evidence of past history of seizures. Next. For treating alcohol dependence, we have disulfiram, naltrexone, and acamprosate. Next. Disulfiram is a deterrent therapy and is used for half a century now, almost. Initial reports said that it is not effective, and it's really not effective if it is not monitored properly. So if you are giving disulfiram, it needs to be properly monitored. It should never be given without the knowledge of the patient. Sometimes it happens that the spouse of the patient comes, that you give some medicine which could help us in getting you good alcohol, and surreptitiously this drug is given, which may prove to be better in those cases. So, we discussed about the metabolism of alcohol. This acts at the level of acid aldehyde dehydrogenase. It inhibits, this drug inhibits that and makes acid aldehyde levels in the blood increase, which may increase even up to 5 times as compared to those where disulfiram is not given. And the reaction which can be caused is there could be clutching, weakness, tachycardia, dysphoresis, nausea, vomiting, headache. These are the usual features which are very unpleasant for the patient. Disulfiram is found to be efficacious as compared to placebo, and the usual dose is 250 mg per day. Metronidazole is also a drug which is a deterrent drug and has a similar action. But of course it doesn't have many clinical trials, and it clinically has not been used. Next. Naltrexone is another drug which is an analog of naloxone, and it's a new opioid receptor antagonist. It blocks the action of opioids at new receptor. But the question arises, how does it happen in alcoholics? The animal studies have shown that in opioid receptors also modulate or they mediate in the reinforcing effect of alcohol. This has been found in the experimental animals. That's why it is also used in alcohol patients. Naltrexone 50 mg per day decreases alcohol consumption as an adjunct therapy and also reduces alcohol craving. And in contrast to acamprosate, this drug has got some relatively more side effects which are intolerable at times, like poorly tolerated side effects such as nausea, headache, hepatotoxicity, which limits its therapy. But still it's being used and it's available in India, and many of us are using it. Next. Acamprosate is a compound which is structurally similar with GABA. Gamma minoputarative GABA, which is has affinity for GABA A and GABA B. and it inhibits the glutamate effect at the mandala receptor, and it normalizes the dysregulation of glutamatergic system during alcohol abstinence, and that's how it prolongs the abstinence period in patients where glucose has been given. Because this drug is poorly absorbed, that's why a relatively higher dose is required, up to 2 grams per day. This drug is also available here in India with the strength of 333 milligrams, and generally 2 tablets twice a day are given to the patients for better efficacy, and it's found to be efficacious in those patients where you need preventing the relapse, and it has been found that relapse could be prevented even up to 12 months post treatment. Next. There are many studies, one was by Manchester and other by Earth. Both the studies are found to be quite effective post treatment, and they could stay abstinent for quite some time. Efficacy of this drug and naltrexone is also assessed. They have been assessed individually as well as in combination, and it has been found that the combination is more effective than the individual drugs. So combination has also been tried. Of course, I don't have any Indian study where they have tried it and COVID. Dopamine is another drug. It is used in alcohol dependence. It is an anti-seizure, anti-epileptic drug. It has got multiple actions. It potentiates carbohydrate transmission. It blocks AMPS. It inhibits sodium and calcium channels, and it also inhibits carbonic anhydrase. That's how it makes more of dopamine available, more of dopamine and epinephrine available. And with these effects, dopamine is used for the treatment of alcohol dependence by blocking the reward effect. And in one of the studies, a 12-week study was found that it is thinking as compared to the. There are many studies, of course, of this kind, but this study was in the boarding here. Then there are serotonergic agents which are used like SSRI, lucidine and citalopram, which is also being used, and their efficacy has been demonstrated in patients with alcohol dependence. And the mechanism of action is that while H3 antagonism is there, and one drug which is called ondansetron, which is recently studied and was found to be effective in reducing early onset alcoholism, particularly adolescents, which was found to be quite effective. This drug of course is not available. Next. Then coming to the cannabis. You know, cannabis is an illicit drug. If it is transported, consumed, manufactured or traded, it is illegal. And this is one of the commonest illegal drugs which is used. There are about 160 million cannabis users in the world, and most common dependent on any of the illicit. So you know that cannabis is derived from cannabis sativa, a plant. In the different portions you get different products like ganja, palm, terrace, hashish oil. All these are the products of cannabis sativa. And there are many chemicals which are present, and the most important one is delta-9 tetrahydrocannabinol, which is also known as THC. And the effects of this are euphoria, relaxation, dreamlike state, altered perception, anxiety, paranoia, and increased appetite. Increased appetite is a very striking and common feature in these persons. Next. So in withdrawal, we see the person becomes angry, aggressive, he develops anxiety, depression, their strange dreams, and there is a physical appetite. And withdrawal generally starts within first 24 hours after the last dose. And the medications which have been tried, these are just tried medicines, are bupropion, divalproate, naltrexone, naltrexone, and sonabinol. These are the drugs I am coming to this. These are the drugs which are commonly used for withdrawal treatment as well as treatment of next. So, tetrahydrocannabinol is a partial agonist at the cannabinoid B1 receptor. And these receptors are found in abundance in basal ganglia, cerebellum, hippocampus, and cortex. As I have already discussed, the cannabis stimulates appetite and drug seeking. Dopamine is released in the mesolimbic system as the usual mechanism of action of any drug, and it enhances electrical stimulation reward, and it establishes conditions place preference and drug seeking self-administration. Next. So I have talked about these drugs which are used in withdrawal. That is, one is naltrexone. Naltrexone, I don't know how many of you have heard of it. This is an antidepressant drug, and it blocks the postsynaptic 5-HT2A receptors and makes norepinephrine available in the synaptic lab when the blood level is increased. And 450 milligrams of this drug per day decreases anxiety, muscle pain, but not other withdrawal. So this is this has been tried. Naltrexone is another drug which is analog of clonidine. We know that clonidine is notorious for hypertension. This drug that way is a potent vasodilator and antihypertensive, and 2.4 milligrams of this drug given for 8 days reduces restlessness, upset stomach, and improves sleep but causes headache. This drug also causes something like clonidine. Sonabinol is another drug which is anti-emetic and appetite stimulant, and it's a partial agonist at the CD1 receptor, and 10 milligrams of this drug given for 5 times daily for 6 days decreases craving, anxiety, misery, chills, improves sleep, anorexia, and weight loss. And it's said to be the most effective of all these drugs that have been tried so far in cannabis. For dependence as such, Rimonabant is one drug which is used, and sonabinol is another. These are the two drugs that have been used in case of cannabis dependence. So this is a antagonist at cannabinoid B1 receptor, and it attenuates, it blocks the effects of cannabis, and 90 milligrams of this drug reduces cannabis effects in up to 40%. And 40 milligrams of this drug which is given for continuous for at least 3 weeks, it is found that it reduces cannabis-induced tachycardia. Sonabinol is given for 10 to 20 milligrams 4 times daily. It blocks the subjective effects of smoking cannabis, but not reinforcing effect. So its effect is limited only for blocking the effects of the drug, but reinforcing effect is not blocked. preventing relapse, these drugs have been tried, and it has been found in recent studies that dronabinol 20 mg 3 times every day and lofexidine 2.4 mg daily is given. They have been evaluated both individually as well as in combination in various drug trials, and it is found that combination of these two drugs was 50% more effective than the effect was double as compared to using them individually. So the combination was also more effective. Next. Now coming to the narcotics after cannabis. What is a narcotic? What is a narcotic? Anyone who can try? Narcotic drugs are those drugs which decrease pain, centrally acting drug with decrease the pain of the person. Opiates are narcotics. So narcotic drugs are the natural alkaloids and their decomposition methods. Morphine, codeine, cocaine, synthetic one, heroin, methadone. We have narcotic and psychotropic substances act. I don't know how to give you the word today. So in withdrawal case, you have to manage the heart rate and passive restlessness, seizures, and optic size, which is dilated in the withdrawal, and current age, which is there, running nose, AISS, tremor, yawning, anxiety, irritability, mood, and skin. These are the common withdrawal symptoms that we, particularly in case of heroin addiction withdrawal. For opioid dependence management, generally done with methadone, now, buprenorphine, naltrexone, or buprenorphine, naloxone combination. These are the drugs that are generally used. Methadone is not available. Methadone is a opiate which is long acting. Its action lasts for 24 hours. And this is basic drug. It is not illegal. It is available otherwise. But for various reasons it could not be brought to India so far. So once a day dose is effective in managing heroin addicts. It is an agonist and blocks the effects of other drugs if given in higher doses like 100 milligrams. And for maintenance therapy, it is generally given 20 to 30 milligrams and every alternate day 5 to 10 milligrams. And higher dose of 80 to 100 milligrams per day is more effective in reducing the illicit opioid use like use of heroin. LAM is another drug, that is neo-alpha acetyl methadone. This is still longer acting. It actually lasts for 72 hours. So it can be given twice a week. But it has got many cardiac problems, including problem and other side effects like ventricular tachycardia and then myocardial infarction. These have been reported to this. Next. Clonidine, of course, is used in these patients. It has got already discussed, it is a calming effect, but it causes hypertension that limits its therapeutic use. Lofexidine is which is analog of this drug, which is tried in some countries, and in the double-blind study, it was found to be effective in cases of strong opiate dependence. that it acts as an antagonist if it is used in combination with other antagonists like buprenorphine or naltrexone. Then it becomes buprenorphine is a drug that was synthesized in 1963 and it is a potent analgesic and it is used as an analgesic in moderate pains. In 1970s, buprenorphine was started to be brought in use as a substitute for morphine to stress opiate withdrawal symptoms. It has got its own moderate withdrawal symptoms, so it also has a very careful. So short-acting opioid receptor antagonists like naloxone is effective in preventing non-fatal overdose. So because it has got a addictive potential, so it has been combined with naloxone and the combination is available here in India. So it can be used once a day in the ratio. The strength of this combination is 4 to 1. 4 times it is buprenorphine and 1 time it is naloxone. The combination has got 2 milligrams of buprenorphine and 0.5 milligrams of naloxone. So this combination is used and it is found to be quite effective and it is being used for clinical purposes. Next. So these are the drugs which are used and the preliminary findings are quite promising in these cases and their future course of action for the long-term experience will be a subject matter of time to come to tell. Next. The cocaine dependence patients pharmacotherapy uses amantadine, which is it augments dopamine release and it inhibits the reuptake of this drug and the mechanism of action remains the same. Diazepam is also used in cocaine addicts and this also acts in a similar way that it is found to be in drug trials quite effective in de-addicting the cocaine patients. Then there are other drugs like Dia-B, that is a anti-seizure drug and it increases the synaptic levels of GABA by inhibiting GABA transmission. It acts on the GABA transporter and 24 milligrams of this drug even for 10 weeks is found to be reduces the cocaine addiction. Baclofen is another drug which is an antipsychotic drug. It is also selectively agonist at the GABA-B receptor and baclofen given for 60 milligrams per day for 16 weeks in a double-blind study was found to be greater efficacy as compared to so
very important, though most of the time as psychiatrists we are not asked for tobacco. As far as alcohol is concerned, we are using it to proceed. The alcoholics, I feel, they are not so much in control of their lives. To take unsupervised 2 tablets 3 times a day of it can proceed. Their personalities are disintegrated, the questions of social supports have gone. For them to remember 1 tablet per day is possibly good enough, so I generally prefer naltrexone. And I would like to ask Professor Deborah about the efficacy of dopamine. You have mentioned that one primary study has said, but how robust is the overall evidence in favor of dopamine as an effective drug for alcohol dependence?
The reports are quite conflicting available. They say that results are quite promising, but it is very difficult to say authentically at this stage that yes, this is a drug of choice in case of alcohol.
Does the US FDA approve it? No. One more question, that's morning. There's a from one countries and people using it in place of regular tobacco and cigarettes, and they provide nicotine at a certain rate by burning some substance. And have you heard of that? And how recommended or not recommended is that as a method to quit smoking, or using it as a method of providing nicotine which is less of the tar?
Many have claimed that they are coming with lesser amount of nicotine. Some come with saying that there is no tar in it. But cigarette is cigarette. If nicotine is 100 gram in one cigarette, or it is 0.001 milligram, that doesn't make any much difference because it's highly addictive drug, and when nicotine is there in it, it is addictive and it is going to cause harm to the body.
To nicotine free electronically, and they are available in India. Two centers have tried it. Dr. Sidhana has tried it, but it's found to be useful in some of the patients. Okay, Jawad, would you like to ask?
In USA, I also visited few places during my WHO fellowship visit, and I found that many of the centers, particularly the University of Washington at Seattle, they are doing a lot of work on networking for the adolescents. They are enrolling all the adolescents, and they are keeping track of all these adolescents in their schools, and they are forming nutritional status. These things you have to ensure first before you start on the addiction or making him good alcohol. So the physical comorbidity has to be taken care of. That should be the priority in the service.
Request Dr. I.J. Sharma, who is an eminent psychiatrist from Delhi, to kindly present a memento to Dr. R.C. Jaloma as a token of respect and appreciation.
सॉरी मैं आपका 1 मिनट लूंगा। असल डॉक्टर भाग्य ने मेरा नाम पुकारा था। डॉक्टर चिलोवा हम लोगों के टीचर रहे हैं, और उनकी जब भी टॉक होती है तो बोलने लायक होते ही नहीं। हम लोग तो ये मान के चलते हैं सचिन खेलता है क्रिकेट में, तो एक बार अगर वो टॉक दे देते हैं मेथोडिकल पूरा का पूरा नॉलेज और इतना सेटिस्फाइंग होता है, हम सब लोगों के लिए बोलने लायक होता ही नहीं। बस एक चीज मैं ऐड करना चाहूँगा, जैसे डॉक्टर जबर ने बोला, डॉक्टर साहब वाराणसी में रहते हैं और हम लोग हापुड़ में प्रैक्टिस करते हैं, तो 2 चीज हम लोग यहाँ पे नोट करते हैं कि जब कांवड़ का सीजन आता है यहाँ पर नुकसान बढ़ जाती है, और दूसरा जो हम लोग अपनी पॉपुलेशन में देखते हैं, गुल की मुसा या मुसा की गुल पता नहीं क्या लोगों को देती है, वो जरिए अपने गांव पे रख करके और उसके
May I request Dr. Sanjeev to kindly present a memento to our chairperson, Dr. R.K. Agarwal. A senior member and an eminent psychiatrist from Varanasi, Dr. M.R. Jhamar. He was the one who motivated Dr. Chaudhary to organize the CME in Meerut, and he was the first person to register for the CME. May I request Dr. Neelam Rani, who is an upcoming bright psychiatrist and presently posted in the military hospital with a promising career in psychiatry, to present a memento to Dr. Jhamar. Thank you, ma'am. Thank you, sir. Form in their folders, and it is requested that they can fill up those forms and leave them at the reception. This is for ensuring that we improve our shortcomings in the future for our future CME programs. And I now invite Dr. Surabhi Gupta from Subharti Medical College to conduct the next 2 sessions as an anchor person. Firstly, I call upon Dr. Brigadier S. Sudarshanan, Professor and Head, Department of Psychiatry, Subharti Medical College. He has earlier served as Professor and Head Psychiatry, AFMC Pune.
The second chairperson of this session is Dr. D.K. Bhattacharya, Associate Professor, ACMS and Base Hospital, Delhi. He had prominent important posting including tenure at AFMC and was posted at Congo as a part of United Nations mission. He is an excellent academician and clinician. Thank you both of you for taking a seat. The speaker of this session is Dr. K.E.S. Puni. I request the respected chairpersons to take over the sessions from here.
Earlier, even at present. I sincerely hope that this will benefit all of us because it's a difficult area and only a very experienced teacher can convey the message to us. Dr. Odisha.
All of us know historical place, and also Dr. Bernard Bulls, Professor of Infant Psychiatry in Hospital Necker in University. The speaker is having a anniversary reaction. That is one of my students, first student in Jipmar Hospital, Pondicherry, Dr. Sriram, late Dr. Sriram. He was in India. He is a teacher of child and adolescent psychiatry in the United States, one of the universities. He was in India during vacation, winter vacation. And just because of a little negligence, he lost his life. In retrospect, he was bitten by a dog while he was on his way to the bus stop and then go to the airport and go back to fly back to USA. And there, after 1.5 months of stay there, in his family, he's having wife and 2 children. He was taken to, around midnight, he was taken to the casualty of his medical college hospital, where within few minutes after reaching the casualty, he was declared dead. In retrospect, the only incident is a dog bite which he had sustained during the early hours of the morning when he was traveling to the on foot while he was going to the West End in his hometown, Trichy. I just will take it. He is a qualified child psychiatrist from the United States, and he had been teaching students. It's a big loss for the students who are going to get sick or other. Now, before we go into the child psychiatry, let us define what we have. A definition, a quoted definition will help us clarify what is adult psychiatry. It is quoted by none other than Marina Dulkan in child and adolescent psychiatry, and I'm sorry, not this one. She is quoting Sullivan, 1954. A situation of primarily vocal communication. A situation of primarily vocal communication in a two group, that means twosome, a dyad. More or less voluntarily integrated as a progressively unfolding expert-client basis for the purpose of describing characteristic patterns of living of the subject, person or client, which patterns he experiences as particularly troublesome or especially valuable, and the revealing of which he expects to derive benefit. This is a very long sentence. That's why I wanted to project it out. Can anybody? Primary, more or less voluntarily integrated as a progressively unfolding expert-client basis for the purpose of describing characteristic patterns of living of the subject, person or client. These patterns he experiences as particularly troublesome or especially valuable, and the revealing of which he expects to derive benefit. It is psychotherapeutic professional contract, but the communication is vocal, verbal. This is the characteristic nature of the other psychiatry setup. In general, after having defined adult psychiatry, now we have to find out how the children communicate. And for that we have to find out through the methodology of dialectics. There are only two methodologies. One is the mathematical approach and the other one is the dialectical approach, which we are all doing, debating, finding out the logical aspect of it, finding out the truth. How the children communicate themselves with the I'm sorry that psychological medicine journal which is published from UK. So there is a history of this savage infant from the forests of Madhya Pradesh, who were rescued by a picnic party headed by a priest. And the savage infants were taken back to the civilized world, and there, instead of themselves talking in the animal language, that is the sounds and the noise of the animals, they started talking after a few months, few years, the normal usual language, and they started communicating as they grew along with the social others, human beings in that locality, and they learned the cultural inputs, they imbibed the cultural inputs. I will present one particular case where the child presented with talking to self. The talking to self was observed by the father and mother, and they came an 8-year-old girl, and we observed a videotape and again peer-reviewed and found that the child is having a type of imaginative play rather than having any hallucinations. And she was feared by her parents, that she is responding to hallucinatory voices. But whereas in reality she was not. It was only a imaginative play. Another situation where the child was just having continuous crying spells, and they were fearing that the child has some organic problem. They took the child to the pediatrician, and when she was brought to our clinic, she was allowed to play in the play therapy room, and she revealed herself to be distressed because of some kind of a injury which had happened to the hip region, and we found that she doesn't have a real mental health or In child and adolescent psychiatry, the specificities are that children communicate non-verbally, they imitate, they play, they communicate by way of the mediation of toys and by way of the mediation of the other objects like paper, pencil, dust. And in psychodramatic situations, the adolescents communicate by way of their acting and conversation, dialogues with the other characters. In psychodramatic situation, it is better that the therapist and somebody who can act and who can organize an acting is also involved in the psychodramatic program. And there are two approaches. One is the phylogenetic principles and the ontogenetic principles. In phylogenetic principles, we are taking the Lamarckian point of view. The Lamarckian point of view is that the epigenetic is based on the epigenetic principle. Epigenetic principle we can define like this. Those which are learned are also transmitted on to the other generation. It is not only the genetic transmission. Those which are learned and imbibed in one generation can also be transmitted on to the other. This was highly criticized in the Lamarckian. The Lamarckian point of view was highly criticized, and they have contrasted it with the survival of the fittest and struggle for existence, which is formulated by Darwin. But for the present, for the sake of child and adolescent psychiatry, what is needed is the Lamarckian principle. Then only we can practice the epigenetic basis for the therapy of children and adolescents. I will explain. The epigenetic principle is beyond the genetics. We are taking into consideration the transmission intrafamilially, subculturally, societally. These transmissions are not only via the biological genetic method, but also by way of cultural transmission, linguistic transmission, and by way of non-verbal other cultural type of transmission. And these type of transmissions we have to take into consideration in child and adolescent psychiatry. The biological, psychological, social, environmental, cultural, and also interactional. We are talking about today. We were hearing how the biological aspects of different disorders and also different psychiatric diagnoses. We had heard the speakers in the forum, but there is no proof that it is the cause, whether it is the cause or whether it is the consequence. It is not proved yet. So, the environmental causation, the subcultural transmission, environmental causation, and the interactional method of transmission. Whether they are, what we are looking into in child and adolescent psychiatry is whether we are having an interactional problem between the father and mother and the baby, father and mother and the child, father and mother and the adolescent. And these interactional problems are to be tackled on a therapeutic basis, a group program, group approach, where we will take into confidence the father and mother, and the therapy is instituted via the father and mother, via the peer group, and via the subcultural group, in such a way that there is no need for any psychopharmacological approach after a clear-cut diagnosis. For these, the theoretical approaches which are necessary involves we have to study how the thoughts originate in the child and how the thoughts are getting evolved in the child. The abstraction, the level of abstraction, improving in the level of abstraction as the age advances, and these thoughts which are seen in the younger children, younger age group children, can be called infraverbal, prelingual or infralingual, and later they will be, the language will be evolving in these children, and the way of communicating may be different in this age group. The evidence for this kind of pre-linguistic stage, as I have already told you, the babies who were left in the forest or happened to be in the forest, and those children, they really interacted with the animals, and they mimicked the animal voices, animal type of communication. And when they are rescued and taken back to the civilized world, they relearned the language. Because of this story, these children in India, there are two children who are in the story. There is a book, Amala and Kamala. Another story is that of the victor of Aviron, in the forest of Aviron in Europe. Both are similar stories, and they are giving us the inputs for making the linguistic aspects, correction of the linguistic aspects. It is happening. It is possible that the linguistic problems can be corrected in these children by way of the therapeutic approach. So I have, in a very general way, I have just explained to you some of the differences between the child psychiatry situation and adult psychiatry situation. Now, therapeutic program in the clinical setup of child and adolescent psychiatry. For each age group, the therapy is different. For each age group, the therapy is different. For the infant, there are no possibility of any psychopharmacological agent. For the children, younger age group, we will follow the same principle. And for the higher age group, psychopharmacological agents can be an adjunct. And for the adolescent age group, like adults, we may be giving doses which are lower than that of the adults, but that depends upon the psychopharmacology of the drugs. In some of the children and adolescents, we will have to give higher dosage because of the freshness of the liver where the drugs are metabolized, and higher dosage will have to be started in those patients. I haven't gone so much into the specificities of each of the disorders, but in a general way, the recording of the case sheet is depending upon the biopsychosocial, cultural, and also environmental aspects. There is another way of recording the histories of this patient and their findings, that is on a timeline starting from the infancy to the child and adolescent and young adulthood. These are the two different methods of getting the history and recording. Unlike the adult psychiatry, in child and adolescent psychiatry, we have multiple informants. And one of the informant who is outside the consultation room, who may not be available, is the teacher. The teacher will be either invited during a therapeutic session, if it is possible, a personal presence of the teacher will do good for the therapy and also for clarifying the diagnosis, because usually the children, they spend 6 to 8 hours or 6 to 7 hours in the school. Some of the schools start at 7 a.m., 7:30 a.m. and they go up to 3 p.m., 4 p.m. And during their wake alert, interactive wake alert state, the teacher is the observer of their behavior, and they will be able to report. Suppose they are not able to come forward to the clinics of child and adolescent psychiatry, they will be asked to write a report, a comprehensive report, not with the percentage mark or grade or anything which they have received, but their interactional, social, communicative behavior in the school, curricular and extracurricular activities, and last but not the least, about the homework, the day-to-day work done, and also the percentage mark or the grade they have achieved. And these reports also will be either corroborative or ruling out certain aspects of the diagnosis. And usually, for the infants up to 3 years, there is a separate classificatory system which we are following. And in this system, it is not like the ICD-10 of the adults or adolescents. They have noted on the larger stages of the behavioral problem. It can be larger stage of a future behavioral problem, which will get well installed in their psychic realm, or it can vanish by way of therapeutic intervention. So early detection and early intervention, multiple informants, mediation by way of objects, that is play materials, or by way of psychodrama or group therapeutic program, taking the help of teachers from the institutions where they are studying. These are some of the methods, general guidelines in the practice of child and adolescent psychiatry. The environmental impact in India is very much visible. The environmental impact is very much visible with regard to, you might have heard about the endosulfan poisoning, the encephalitis, the Paysanur forest disease, and encephalitis and dengue and other infections which are playing a major role in the causation of neuropsychiatric problems. It is interesting, the latest neural reuse theory, apart from that of the neuroplasticity, the resilience, the basis, biological basis of the resilience of the children, the neural reuse theory by Henrich, 2010, Philadelphia. And also the method of normalization. Normalization means engulfing the component, the traumatic component, whether it is psychic component or the trauma for the brain, for the coverings or the tissues of the brain. These components, how they are engulfed, how they are metabolized, how they are normalized in their individual capacity with the help of the family members, and how we are trying to help them to come out of the problems with the help of professional interventions. This is child and adolescent psychiatry. I am sorry I have gone astray a little bit because of the real trauma which I myself am facing because of the demise of my student. I am sorry for that. If you have any questions, you can ask.
Important aspect of assessment in children, particularly underline some of the theoretical concepts behind the need for such an assessment. Now, the topic is open for discussion. We invite some questions, particularly from the postgraduate students.
I think Sir has contributed a lot. So far, the conceptual issues in assessment of child and adolescent psychiatry are concerned. I think that is the most tough area in approach towards child and adolescent psychiatry. Then the application part comes. I think Sir will be answering both the aspects. Particularly in the residents, if they have any query or anyone has any comments to.
Sir, I'm Lieutenant Chandrasekhar, sir. I'm a psychiatrist at the base hospital Delhi. From what I understand, during child psychiatry practice, playroom is an essentiality if you have to practice child psychiatry. Am I correct, sir? Because the morning speaker had said that adult psychiatry practice child cancer.
Really, a playroom is central for a consultation in child and adolescent psychiatry. Play therapy is both therapy and also diagnosis. The moment the phone call comes or the child registers or enters the room, the professional involvement starts. The child observation starts. And the therapeutic process and the diagnostic process are going side by side. The formal, what I am seeing is, when patients get referred to us, the very formal method of that recording of the IQ, utilization of the scales, the neurological investigation, neuroradiological investigation, everything is perfect. But nothing is done for the therapy of the patient. The patient remains the same. His or her problems remains the same. We are concentrating on the diagnosis and therapy on a clinical basis. The other methods are contributory or secondary. It is not that I am telling that I am disregarding the importance of IQ. We have to do the IQ, but therapy should go side by side. In addition to the play therapy and the focused on the child and its behavior, what we have to do is we have to tackle the distress of the parent. Who is suffering? That is the question. In smaller the children, the sufferer are the parents. Say for example, a hyperactive child. The sufferer, they are the parents, especially the mother. They will be exhausted running after the child who is hyperactive. What I am trying to impress upon anybody is that why should we wait the full-fledged ICD-10 diagnosis of hyperactivity attention deficit disorder? Why should we allow it to happen even before that? By educating approach to the parents, they will be able to come with the larval stages of a ADHD and take a consultation and therapy so that we will be able to prevent a ADHD happening in the child. That is my message. I have seen in front of my eyes, I couldn't believe it during the 3 years of training. There were 3 girls and 1 boy. They had been starting the therapy, they had been undergoing the therapy from their age of 2 years. The parents came for a psychoeducative program in the community center. It is called the CMP, Sandra Medical College. In the CMP we are also posted. We continued the consultation with the co-consultation. Therapist, the consultant will sit, ourselves the resident will sit nearby and do co-consultation for each of the patient. And they have improved without giving any mental candidate or any psychostimulant or thyroregulator, that is mood regulator. They have improved, they have gone back to the school, they have continued in the school, and they have done quite adequately well in the exams. That is what I am interested in. Finding out the larger stages of behavior.
So we engage the child in drawing and painting. In the particular drawing and paintings, typically the person is having obsessional thoughts of some aggressive thoughts, and he is saying that obsessional images of cutting the throat of different animals, blood is coming to his mind, and the total obsessional thought is reflected in his picture. Most of the pictures is showing accidents, cutting the throat of a cow, and showing part of the total picture is most part of the picture is shown by blood and all these things, and the person is also having courage. So aggressive thoughts is violent towards parents as well as the other inmates of the hospital. So we have planned to channelize his aggression in a creative way. So we plan to engage the child in some outdoor sports like playing football, cricket, and most of the time he is involved in these sports. He is trying to hit the ball with maximum effort, and he is channelizing his aggression in creative activities. And with this, all these things, play activities, physical activities and sports, and we see that long-term hospitalized, and we see that his aggressive behavior is reduced, and both combination of pharmacotherapy as well as supportive psychotherapy and play therapy and all these things is possible.
What is the age of the child?
Sir?
What is the age of the
that is 13 or 14 years old.
So he is an adolescent, middle adolescent, 3 years. And the progressive improvement is seen in the pictures.
Yes, sir.
Isn't it?
Yes, sir.
Now, I didn't give the message that keep quiet and do something, cooperate with us for the therapeutic sessions.
The patient for OCD we are giving Subharti, and for aggressive outpost we are giving risperidone and antipsychotic low doses, and for ADHD we are giving information with methamphetamine. And the follow-up we see that the percentage the improvement seen in the hospital is not equal in the at home, because after discharge it is seen that much of attention is not given by the parents to the child. It is not engaged in play activities, and that much of creative activity is not provided by the parents. And again the symptoms reemerge.
there I will prefer to differ. Regarding the pharmacotherapy with the neuroleptics, that is antipsychotics, my impression is that what I was taught by my professors is that any trauma to the brain, visible or not visible, history-wise it is there, but it is not visible in the neuroradiological examination. In such cases, neuroleptics, it is better to avoid. If we are instituting therapy, we will get a quick improvement in the patient. The hyperactivity will come down. But there is a future possibility of an early cardiac dyskinesia, extrapyramidal symptoms, early cardiac dyskinesia. Hope you know that the trauma, cerebral trauma is mental retardation, cerebral trauma, rapid cycling, affective disorder, etc. The treatment with haloperidol, etc. are forerunners of tardive dyskinesia. Nowadays, tardive dyskinesia is much less because of the newer antipsychotics. But still, there are other type of side effects. So I will keep away from using the neuroleptics, but I will be happy to utilize anticonvulsants, which are also mood regulators. There are reports in American Journal of Child and Adolescent Psychiatry, and also in two issues. There are reports on how carbamazepine monotherapy is helpful in hyperactivity. Nowadays we have oxcarbamazepine. In this particular child, I would like to utilize. If he is not behaving properly, it is not a punishment. I am not technique.
I invite Dr. R.C. Gupta to present memento to our chairperson, Dr. Bhattacharya. Dr. R.C. Gupta is a renowned pediatrician currently residing in Modinagar with interest in child psychiatry. I invite Dr. P. Prakash Bhosla, Professor and Head, Department of Pharmacology, Subharti Medical College, Meerut, to present memento to our second chairperson, Dr. Sudarshan. Dr. Bhosla is MD and DM in Clinical Pharmacology from PGI Chandigarh, and he has also done DND Clinical Pharmacotherapeutics. He has special field of interest in psychiatry and in clinical pharmacology in India. Thank you, sir. This CME by Dr. Usha Nair. She is patiently waiting for her turn. The chairpersons for this session are: first is Dr. Sanjeev Shahji. He is a senior psychiatrist from Aurangabad. I request Dr. Shahji to come on the dais. And the second chairman is Dr. Indrajit.
Scientific papers to the credit. Said brave woman because father, late General PDP Rao, has retired at DG AMMC, and all her children have also served in the army. So she is the woman with a brave heart. I welcome Dr. Usha Naik for her presentation.
Thank you, Dr. I'll start. Not yet. There's too many things at one time. So we're really looking at what's normal. So almost every one of you is an expert by yourself, except for the little lotka. I'm sure most people in this room are parents or have been uncles and aunts and so on. So we just start. So we're looking really at normal practices and which of these practices have stood the test of time. What are the focus points? First, what is parenting? Who are the important contributors? The third is a little bit of field work we did for UNICEF, interplay, discipline, parenting styles and so on. I'll try to be quick because I'm sure the road back to Delhi is quite terrible. We had a tough time coming in. The most important topic in all this is discipline. Before we continue, would any of you tell me what you think is discipline? PGs?
Behaving within social expected norms.
That's right. behaving within socially expected norms. Any other? Okay. So if you go away from here knowing a little more about discipline, I'll be glad. What I'm going to talk about, if you read the abstract which I finally said, about in 1991 I read an article in the pediatric clinics of North America. I believe we have a pediatrician here. This was perhaps the finest article I've ever read on parenting, because the definition of parenting in this article was as structure. That discipline is structure set up by parents and caregivers to help the child feel capable and lovable. So you'll see more of this, but if you remember, we had a pediatrics professor called Dr. Sheila, she'd come into a class and she'd say, "Wake up all you backbenchers." So we'd wake up and she'd say, "Iron deficiency anemia is the commonest anemia in South India." And then she'd say, "Go back to sleep." We never went back to sleep, but 40 years later, I still remember what she said. So if from this class or this lecture you take away one statement, take away the statement that discipline is structure. Okay? Now parenting, this definition. By the time you get to be emeritus professor, you're entitled to make up definitions. So parenting refers to the rearing of a child by caregivers. It encompasses a wide range of activities which promote the psychological and physical well-being of the child. Don't take notes, we leave it on the desktop and they can have a printout of it. Important contributors to the field, Freud's fallen by the wayside, but he still left us a lot of good stuff. Erikson, Benjamin, Spock, Illingworth, Montessori, and maybe talking a very little bit about some of them. Of these, as a textbook, I'm sure the pediatricians used Illingworth as a Bible. For all of you psychiatrists, whether or not you're interested in child psychiatry, please read The Normal Child by Illingworth. It was written in the 80s, it's written with humor, and most important of all, it tells you what's normal. If a mother comes to you and says, "My child doesn't eat a plate full of food at 1 year," Illingworth would have told you how much is normal at 1 year. Now, in addition to these experts, this is the magazine, Week magazine of 7th August. It's on parenting, you can read that. It tells you what parenting styles, Asian tiger moms and so on. We'll talk about Asian tiger moms. Erikson, don't want to spend too much time on him, but though he didn't really have the qualifications, he taught at Harvard, and what he said is that up to adolescence, it depends on what is done to the child. From now on, what the child does becomes important. If the child comes out of this, there's no real confusion, and the child gets his own identity. Benjamin Spock, famous pediatrician, I brought up my children reading some of his manuals, though luckily not only his manuals. There were two things he said which wasn't great. Like one of them, he said, put the baby on the stomach, and sudden infant death really was probably because of that. Fortunately, Indian mothers have always put their babies with looking at the ceiling. The other thing he said which wouldn't go well with Indian parents is don't pick up the baby when he cries, he must learn not to be picked up. No grandparent would have tolerate that, no mother-in-law. These were his books been reprinted hundreds of times. Most of the rest is pretty sensible. Illingworth, my Bible for teaching postgraduates. In fact, I bought at least 6 volumes, always pinched by postgraduates. Maria Montessori, she was a psychiatrist. She revolutionized the idea of play schools. Her motto was follow the child. She thought each child was unique and had all this within him waiting to be revealed. And her methods stood the test of time because the child learns at his own pace with his own interest. These are 2 books. The one on the right, How to Raise a Brighter Child, is really about how we did a program for UNICEF where we followed up in the slums of Hyderabad, low-birth weight babies, babies born with hypoxic encephalopathy stages 2 and 3. The first thing we gave each family was a little rubber ball with silver paper stuck with it to hang on the frame. That was one of the ideas I got from this book. That is, give the baby something to look at for in the first few weeks of life. Educated parents would do that anyway. The book on the left is called Questions Parents Ask. It's from the Gessens Institute of Child Development, and it's an amazing book because almost everything parents ask are answered very sensibly. Time, Daniel Goleman. There was a chapter on emotional intelligence in the last edition of comprehensive textbooks at the 8th. The 9th doesn't have this chapter. So go back and read it from the 8th, because this man, Goleman, he did a little study. He found people with Mensa type IQs, 140, 180, 200 were bus conductors, brilliant men, endocrinologists. But he couldn't stand the kind of... Whereas the chap who's emotionally smart will understand that there is politics in it. Studied Goleman. He studied little kids who were 4 years old, and he gave them sweets, and he said you can have 1 sweet now, or you can have 2 mush. He would pace up and down, bring their hands and somehow wait. And when that man came in, passed the marshmallow test, when they grew up, went on to become leaders of people. So there is something in the child, something we can develop. But when we don't have emotional intelligence, we don't use our full potential. Now, this one that Week magazine said the Asian tiger mother. All this started around January this year when this Chinese mom called Amy Chua, she is married to learn a piece called The Little White Donkey, a piano piece. And this girl was made to play it and play it through the night because she was making one single mistake. It is not a how-to manual, it's a memoir of what I did wrong as well. But as psychiatrists, people might ask you, so Google that stuff. Now this is very briefly what we did. This is the mother-child protection card for the... You can Google this and get it. It's the UNICEF Shishu Samrakshan card. What we had helped to develop was a series of activities for parenting, along with simple milestones for early detection and intervention for delays. So if you Google Shishu Samrakshan, you can get the website. There's a little bird which leads you to it. Chandrababu didn't want it, so it's still lying with UNICEF. This was how the milestones look. These got 30 items with no cost. The costliest thing was a pencil. We'll ask the child to track, otherwise it's fused with stones and whatnot. So using these, it was like an Indian Denver. We had standardized the Denver test for UNICEF one, which come in the next slide. This is a pre-parenting activity. Should show affection for the child. You should talk to your child. Both parents should do this. Affection, play and talk.
For giving us the opportunity to share this session. When the session started, I thought I am the best parent doing the best parenting. But in the end of the lecture, I learned I am the worst parent and did the worst parenting. शायद ये लेक्चर ऐसा था जैसे कभी आप मकान बनाए ड्रीम हो, उसमें बड़ा अच्छा इंटीरियर करा है, बड़ा अच्छा एसी लगाया है, और जब आप अपने फ्रेंड के घर जाते हैं तो आपको लगता है काश इसका आर्किटेक्ट या इंटीरियर वाला मुझे पहले मिल जाता। तो आई थॉट कि मैडम का लेक्चर शायद हम लोगों को पहले मिल जाता। When our children started growing and we started parenting. But I am glad enough that our younger colleagues who are just going to be married in a few years will learn a lot from this good thought-provoking lecture. I think and hope that next time जब डॉक्टर चौधरी इसी तरह का सेमिनार करते हैं तो आज का सर जो मीटिंग था वो पहले सुनते कि नॉन वर्बल कम्युनिकेशन चाहे कैसे होता है, पेरेंटिंग फिर हम कैसे करते, फिर साइको एंडोक्राइनोलॉजी प्रॉब्लम्स को देखते और लास्ट में ड्रग डिपेंडेंस को देखते।
But I thank Professor Subharan, Dr. Chaudhary, his team, giving me the opportunity to chair this session, and I give my colleague and open the session for other speakers.
Dr. Psychiatry, KMC Lucknow. Ma'am, thank you for this wonderful presentation. I have just one question. I usually see child and adult psychiatry patients. Most of them come with behavior problems. The parents come and they say, these are the behavior problems and I want you to correct them somehow. When we told them about behavioral methods and style of parenting, authority and those things, they usually will say कि डॉक्टर कोई दवाई दे दीजिए and that will make all things better. But when we say this is the best way, they will start making cases and they are not very much encouraged with this. They have to make their own effort. They will say they will try. How can we motivate those parents? Most of the parents.
One thing, it depends on medication. For example, this morning we're talking about the ADHD. I would never start a drug till at least 3 months of intervention with the child. Plus, over the years, we've developed the method of interacting with the child, with the parents outside the room. And we tell the child this is 100% confidentiality. I'm sure you know as a psychiatrist you have to break confidentiality if your patient is going to kill someone else or himself. Other than that, you don't have to communicate. You must remember that you're on the side of the child against the whole universe. And then you will tell the child that can't you shape up, otherwise they're going to medicate you. And similarly, I've known children who, mothers, American children posted in exercise. We should tell the parent, give yourself time, 6 months, 1 year, because social anxiety is a real problem and it can manifest when you become a... Of course, we should be careful we're not dealing with any syndromic conditions and so on. And in the absence of that, the behavior should be shaped. Then the mother will work with it over the next year. And then what we usually suggest to parents, not only for social anxiety, social avoidance, and even for selective mutism, is selective mutism, the child won't talk in school, but talk at home or vice versa. So we ask the parents to slowly build up a peer group relationship for the child. So one child who goes with her to school should come home and play with the child. So they should have positive experiences together. I don't know what other parents noticed. We have noticed that when we were kids, we had such thick friends. So that's a good time to make a little peer group. Neighbors, sometimes mothers say the neighborhood is dirty, we don't want those friends. So whomever the great mother thinks is good enough for her child, she should get home, she should take this child to their home, and preferably from school so the child sees the same person there, and build up relationships over time.
School or is not going to school because he's gone into bad peer pressure or whatever. And the parent was not able to realize that, and the child is missing out on studies since last 2-3 years. And then of course he's into depression and anxiety, and the parent is again blaming him for it. In that case, when we are counseling the two, do we not have to tell the child that it was partly the parent's fault? Just to build up his confidence and to tell him that the parents should be helping him and this is what the parents missed out, and they should have seen to it that it was not totally his fault that he went into bad peer pressure. I'm asking you this question.
You know, there was what Erickson really called it was a moratorium. Now, a moratorium is a legal term. Supposing you have to pay the bank money by August 1st, they may give you a moratorium till September 1st. So adolescence, Erickson said, was a moratorium period when a child can keep his responsibilities on hold. So something is evolving in him, he's growing up, he's gaining his own identity, sorting out his confusions. So in this process, he may be depressed, he may be acting out. So what, I don't know if...
Presentation on parenting that I have come across after a long time. So for the issue of medication and behavior modification or structuring is concerned, I fully agree with you that you must try at least 2 to 3 months with environmental, behavioral and other modification, and on majority of occasions we will be successful.
Being treated by Shekhar Sheshaji in hands for many years. They couldn't say whether it was bipolar, they couldn't say whether it was schizophrenia. Nobody knew what the treatment was, all kinds of bad, yes, no. I'm saying we need to know the antecedents of what happened in a child's life. And how terrifying. This afternoon the bathroom door would open and I was saying, I don't want to be here. I went in there and that thing both wouldn't move and I'm 60 years old and this kid was there overnight in the school bathroom. So I think we have to see the...
I request Dr. Chandrasekhar, classified specialist at Gates Hospital, our chairperson, Dr. Shahji. Thank you. Now we invite Dr. Sachin Sharma, Faculty of Psychiatry, Subharti Medical College, to give a comment to Dr. Indrajit Sharma. Thank you, Dr. Sachin. Now coming to the closing day, I request Dr. Sandeep Chaudhary and Dr. Sachin Sharma to summarize the whole day's event.
Days and I think all of the people, they have had enough. As far as the time is concerned, they won't like to listen to my summaries. But I'm thankful. I'm thankful to all of you who came here and participated in this CME. And I am thankful to all the pharmaceutical companies, Dicene Pharma, Sun Pharma, Intas Pharma, PV Labs Limited, Health Plan, Virat and Raj Medical, and Ambrona Pharma, who have supported this CME. And without their support, we were not able to proceed like this. We were not able to perform like this. And I'm thankful to my esteemed speakers who have given us chance to listen to them and to inculcate some knowledge. Also to Dr.
Secretary here, especially please keep in mind that our department is also the child. It's not too many years old, hardly 5 to 7 years old. So we know admit we must have made lots of mistakes here. So we'd like to apologize for any inconveniences caused in that way for all those small possible errors. I'm especially thankful to even the other, I call this a symbiotic association participation. Lots of departments other than psychiatry have been very cooperative in the success of this CME, especially all the hostess and all the people around, all the volunteers. Without this, we could have never managed with such a small group. So, bravo to Dr. Chaudhary. In fact, he was one who brought the CME here to the command. And thanks to all the team.
These are our shortcomings, some of our shortcomings, some good things.
Considering child and adolescent psychiatry, I think department has done wonderfully well. So personally, I know Brigadier Sudarshan earlier in the armed forces, right? He has been my senior colleague and also a teacher. But seeing him work here, I find him more energetic and I would say sir has appearing less in his age, so many activities are concerned. And once again I compliment your entire team, starting for your reception to the
7 p.m. So all of you are invited with your families. And please, because we didn't include the coupons in the folder, so those who are participating, please collect your coupons from me.
सामने देखिए इधर, यस, इधर देखिएगा। सामने देखिए इधर, यस।